Well, I just learned that Jean-Pierre has a delay and therefore he has not yet arrived at the airport. So I think that we will start and then he might join us later on. So, just a few housekeeping. The first thing, please speak on the microphone every time you have to say something because we are connected. We have some people connected online and this is it. I don't think I have other housekeeping. So just let me welcome all of you really sincerely to this small but very intense meeting. I have 2 or 3 slides for those of you, the few of you who have never been here before, just to say what EICA is and what are the main goals and activities that we carry on. EICA was founded in 2016, and it was actually conceived by Professor Crepaldi, who was my mentor from the University of Padua, and Jean-Pierre Michel. At the time, he was the president of the European Geriatric Society, and then myself and several other scientists working in the field of aging, but not from the clinical or epidemiological point of view, mainly professors interested in the socio-economical, behavioral aspects of aging. In particular, Professor Brugiavini, who is an economist from the Ca' Foscari University here in Venice, and several other economists. The idea was indeed to create a platform to support interdisciplinary analysis, meetings, and dissemination of results related to the aging field. And it was felt at that time that EUGMS, the European Geriatric Society, being a come mai ha questi EUGMS as members the geriatric societies, European geriatric societies of Europe. And this is blanking, but I think that it's going to be said sooner or later, otherwise it keeps. We felt the need indeed to go a little beyond the geriatricians only as a target group of individuals, and therefore we created EICA that has been based in, let's see if I change. Yeah. It has been based in San Servolo because San Servolo hosts the Venice International University, which is a very large consortium of university research centers from all over the world. And from Italy, I would say virtually all the main universities, the National Research Council, are all members of VIU, the Venice International University. But when I say from all over the world, it really means that we have affiliated universities from Australia, from Japan, from the States, from Canada, from really all over the world. And there are many activities all year round, such as schools for undergraduate and graduate students. Last week there was the Summer School on Aging, and it was opened by Luigi Ferrucci, the scientific director of NIA, And then there were students coming from 48 countries around the world. This is just an example of the many activities ongoing in Servolo, and because of this there is a permanent international secretariat that is really helpful when we have to organize meetings. And so the main activities that as EICA we have carried out from 2016 up to now is mainly we have organized the expert meeting on selected domains. We started mainly for the first 2 years on the nutritional field and musculoskeletal diseases. Then from 2018, we had regular meetings on infectious disease, vaccines, and the impact on aging, and this, I would say, has become the main activity in the last 4 or 5 years. We organize conferences and small meetings, such as this one, where we really like to have different reference from the private and the public representativeness, medical and pharma, medical industry pharma, all different stakeholders with specific interest on aging. And this today and tomorrow meeting is one of these interprofessional meetings. Then we had also some master classes. We had, for example, a master class for nurses working specifically in the field of musculoskeletal disease. And this was an activity that was carried out about 2 years ago and led to the publication of a book with Springers on the care of people after hip fracture that has been disseminated and translated in 5 different languages. As also for these meetings, we always aim to have executive summary published in a peer-reviewed journal. That it's actually, it has been the aim of all our meetings, and we have succeeded to have always a publication following this meeting. And one other activity that we had particularly related to the dissemination of results of European projects supported by the Commission was to prepare also after the meeting documents and material to be disseminated for the general population. So according to the target of the meetings, we try to prepare ad hoc material for policymakers, for healthcare professionals, or for the general population. And this is just to give you the overall idea. To the meeting today. The topic was actually suggested by Jean-Pierre Michel, who has been also president of EICA and very, very active, particularly in identifying hot topics in the field of vaccine. And so we have prepared this program with the support of GSK, Novavax, and Sanofi. They have supported with an unrestricted educational grant for all of the logistic, and I'm very grateful to them. We have some reference here. I would like for you to introduce, maybe starting from Laura.
Yeah, good morning, everyone. I'm Laura Zanetta. I'm medical manager for influenza vaccination here in Italy for Sanofi. And thank you.
Hello, this is Marie-Cécile Levent. So I am a colleague of Laura, but I am, you can hear, in France, based in Lyon, working in medical affairs for Global.
Thank you.
Hello, I'm Marta Vicentini, medical lead for RSV in Italy, and thank you for the opportunity to be here.
Hello everyone, I'm Riccardo Freguia, I'm a colleague of Marta. I'm medical lead for Shingrix, so Herpes Zoster vaccine for GSK in Italy.
Thank you very much. The referents of Novavax are going to join us tonight. And I like also to add that all speakers have not received any fee for being here, and I'm very grateful to all of them for their willingness to join this program. The program is, let's see, so that we take the opportunity, it's hard to read, but I take the opportunity to ask the people around the table to introduce themselves. The first speaker will be Dr. Daniela Pedicino.
Good afternoon, everybody. Thank you, Professor Maggi, for this kind invitation. I'm Daniela Pedicino. I come from Rome. I'm a cardiologist and work in intensive care unit and in translational cardiology.
Thank you very much. And then the chairperson for the first session, you see, is Fiona Ecarnot.
Hi, my name is Fiona Ecarnot. I'm a researcher at the University Hospital in Besançon in the east of France in the cardiology department. I'm very pleased to be here. Thank you for the invitation.
Thank you. And Fiona is not only a bright researcher, but usually is the medical writer, and she prepares the executive summaries in our meeting. So, extremely important person. Then, Thor, would you introduce yourself?
Yeah, hi, my name is Biering-Sorensen. I'm a cardiologist from Copenhagen, Denmark, and I'm a professor at the University of Copenhagen in Copenhagen, Denmark. Yeah. And thank you so much. It's a great honor to be here.
Thank you. Nicola Veronese, unfortunately, has some family problems, and therefore he's unable to join us, but he has pre-recorded his lecture. And then we have Thomas.
Hi there, everybody. My name is Thomas Weinke. I'm from Berlin in Germany, specialized in internal medicine, infectious diseases, and tropical medicine. For a period of time, for some years, I was also a member of the German NITAC, the STIKO, responsible for all the vaccine recommendations in Germany. Thank you. It's a pleasure to be here. Thank you for inviting me.
Thank you. Then we have Marco.
Hi everyone, my name is Marco Del Riccio. I'm a medical doctor by background and specialized in hygiene and preventive medicine. Currently a researcher at the University of Florence and member of the scientific secretariat of the Adult Immunization Board. And thank you very much for the invitation.
Thank you, Marco. Then Professor Elizabeth Botelho-Nevers, I think she will connect online later on. I don't think she is already connected now. And then we have Cornel Sieber.
Hello, my name is Cornel Sieber. I have a chair for geriatric medicine in Nuremberg, Germany. Cornel Sieber. I have a chair of geriatric medicine in Nuremberg, Germany. And clinically, I work back home since 5 years in Switzerland, where I'm CMO in Winterthur, one of the largest hospitals in Switzerland. And I'm quite, since early times, with ICA, together with Stefania and Jean-Pierre, and at the moment I'm also past president of the EU GMS.
And the future president of ICA next year. Then we have Stefan.
Hi, I'm Stefan Grabenstein. I'm a professor at Brown University, director of geriatrics, past member of the ACIP, and a vaccine researcher.
Thank you. Marco.
Yes, it works. So my name is Marco Goeibier. I'm an acute internal medicine and critical care specialist working in Haarlem and have a research position at the Department of Virology in Erasmus, Rotterdam.
Thank you.
A member of SB.
Then Anthony Torres will connect online tomorrow, and Professor Volpe, who is the president of the Italian Society for Preventative Cardiology, will join us tonight. And he's, as you see, with EICA, co-sponsoring this symposium. Jean-Pierre will arrive in a little while, then Jane.
Thank you very much, Stefania. My name is Jane Barrett, and I'm a Global Advisor of the International Federation on Ageing and an independent consultant with a real interest in adult immunisation. I also sit on the Equitable Immunisation Group for Strategic Priority 4 and 5 from the Immunisation Ageing Agenda. So I look forward to being with you in the next couple of days. Thank you.
Thank you, Jane. And I think we're done with, we include Michele. Yeah, Michele is our pillar from Aristea, actually. Thanks.
Hello everyone, I'm Michele Rodato from Aristea. Aristea is based in Genova, Italy, but actually we are working on a global scale in supporting scientific societies and the pharma industry in developing new projects and new activities related to the scientific community. We are proud to be the PCO of EICA and UGMS as well. So we are thrilled for today's meeting, and we would like to thank you on behalf of Aristea to be here today. Thank you.
Thank you, Michele. And we will, the other person arriving tonight is Dr. Lorenzo. I'm sure I pronounce it badly, but the representative of the International Pharmaceutical Federation. And I would say, without further delay, I would give the floor to Daniela for her presentation. Thank you very much.
Thank you. Can I?
Yes.
Thank you. Thank you, Professor Maggi, for this introduction. It's really an honor for me to open this Congress, and I would really like to thank Professor Maggi, Professor Michel, and Professor Volpe for this kind invitation. The title of my presentation is The Role of Infection in the Pathogenesis of Atherosclerosis. Actually, a tough topic. I will try to give you my point of view as a cardiologist. These are my disclosure. I have nothing to declare. When we talk about atherosclerosis, we know that it's a matter of inflammation, but it took several years to tell. Initially, atherosclerosis, the inflammatory theory of atherosclerosis was considered a provocative statement challenging the dogma of lipid accumulation in the arterial wall. Now, everyone knows that atherosclerotic disease is a chronic inflammatory condition. This is a fact recognized, and it is in every textbook of medicine and cardiology. This timeline shows the main milestone in the last 4 decades in the research of immune system and atherosclerotic disease. As you can see, there are lots of discoveries in the next 40 years. Going a bit more into let's start from the 80s. In 1980, the application of immunohistochemical technique to atherosclerotic plaque consented to find HLA-DR on human atherosclerotic plaque, as you can see in this black and white picture from a work of Goran Hansson. The subsequent studies demonstrated the presence of immune cells inside the plaque, particularly T cell population is relatively scant in the plaque, but the presence of histocompatibility complex demonstrated their functional activation. The 90s represent the decade of cytokine discovery in atherosclerotic disease, as you can see from these two studies from Peter Libby, documented increasing interleukin-1 production in atherosclerotic plaque smooth muscle cell, and this other work documenting increased apoptosis after incubation with interferon gamma and tumor necrosis factor. In these years, the first genetic modified models of hypercholesterolemic mouse has been produced, and also autoantibodies against oxidized LDL were shown to be correlated with cardiovascular events. The discovery of the association of the pro-inflammatory marker of C-reactive protein with acute coronary syndromes with prognostic implication represented a real step forward in the inflammatory theory of atherosclerosis. So in the subsequent years, a huge amount of studies have been produced confirming this hypothesis with demonstration of increased risk of cardiovascular events in autoimmune diseases, or maybe more recently in patients with cancer undergoing immunotherapies. And also a step forward is represented by this classification of acute coronary syndrome of unstable plaque. We know now that not all unstable plaque are born equal. There's not always inflammation underpinning an acute event. In particular, among these four kind of unstable plaque, the first one, the plaque fissure or plaque rupture, is the most associated with inflammation. As we demonstrated, our group demonstrated the increased frequency of pro-inflammatory cells such as CD4 positive, CD28 null, that is a really pro-inflammatory cell phenotype producing interferon gamma and related to aging, related to autoimmune disease and infections such as cytomegalovirus. Moreover, we documented increased platelet monocyte aggregates mediated by CD31 in these patients with plaque rupture that might at least in part account for the increased thrombotic burden of this patient. So, taken together, all these evidence, we can start to think now to target the inflammatory nature of atherosclerosis. In particular, the targeting innate immunity has gained the clinical maturity in the latest years with this large-scale trial investigating the role of anti-interleukin or colchicine in cardiovascular disease. This is the CANTOS trial, which demonstrated the positive effect of an anti-interleukin-1 antibody, canakinumab, in patients with previous acute myocardial infarction and residual inflammation. Similarly, the trial on colchicine on acute patient, the Colcott, and on chronic coronary disease patients, LODO-CO2, demonstrated the same things with a drug with a relatively safe profile and low cost as colchicine. So we know that there is inflammation underlying atherosclerosis, but there is still jury out about what is the stimulus that can incite these inflammatory bursts. The first effort have been directed in the search of the effect of the common traditional risk factors, such as dyslipidemia or increased LDL. LDL indeed can activate T cells, and also in diabetes, insulin resistant, we have T cell activation, also in uncontrolled hypertension. And cholesterol crystal might induce the NALP3 inflammasome with production of interleukin-1, the same cigarette smoking with endothelial pyroptosis. But what happens when we treat these risk factors? These are two work from Paul Riedker. The first one published in 2017 and the second one recently published on Lancet. These two works say the same things. Looking at the figure in the left, we found the proportion of patients taking statins that are at increased cardiovascular risk. As we see, even with low levels of LDL cholesterol, we have a big portion of patients still at high risk for increased inflammation. And so we need to search for other triggers of this kind of inflammation. And we have lots of non-conventional risk factors, non-conventional triggers for atherosclerotic disease. For example, defective efferocytosis after an infection or air pollution, the exposome, the effect of poor nutrition, mental stress, also local effects such as shear stress profile around atherosclerotic plaque, clonal hematopoiesis, or gut microbiome. But when we look at the interaction between the immune system and atherosclerosis, the most natural correlation is infection. That's why the immune system evolved primarily to protect the organism from infection. And so that's why the infection hypothesis has gone hand in hand with increasing proof of inflammatory nature of atherosclerosis. However, despite positive results from animal study and clinical studies, there is still no robust evidence around a direct correlation between infection and atherosclerosis. And so infection should be considered as a non-conventional risk factor for atherosclerotic disease. In this paper from the group of Zhang, we can see that there is an increased incidence of plaque rupture during the winter season. Every explanation of this fact is merely speculative. However, one of the possible triggers might rely on the increased respiratory tract infection during this period. In this elegant review from Peter Libby are summarized the effects of infection on arterial wall. Several pathogens exert a direct local infection on endothelial cell and smooth muscle cell, but in the majority of the cases, acute and chronic infection, but not only infection, also colonizing flora, may induce chronic inflammation. In particular, viral and bacterial antigens act as pathogen-associated molecular pattern and may induce leukocyte activation through the engagement of pattern recognition receptor. This leads to inflammation, this leads to tissue damage, and tissue damage represents a source of damage-associated molecular patterns, which in turn induce a vicious circle. Pro-inflammatory cytokines such as interleukin-6 may induce acute phase reaction in hepatocyte, increasing coagulability. In this figure are summarized some of the pathogens associated with atherosclerotic disease. Some of them exert general effects, systemic inflammation due to the release of pro-inflammatory cytokines, but some other have peculiar aspects that I will try to briefly summarize. Let's start from influenza, that will be discussed extensively in the next presentation. Influenza has been the more intensive studied virus due to the strong correlation with cardiovascular events, meaning not only myocardial infarction, but also stroke, heart failure, and myocarditis. The general effects are in common with other pathogens and include thrombogenic environment due to increased platelet activation, altered vascular tone, and increased metabolic demand. However, influenza may directly infect endothelial cells, as we can see in this immunofluorescence staining showing in green influenza antigens. After infection, the virus induced pro-inflammatory cytokines and adhesion molecules, which in turn lead to leukocyte adhesion and transmigration. Influenza stimulate the uptake of oxidized LDL from macrophages with increased farm cell formation. Moreover, on atherosclerotic plaque, influenza can induce the thinning of the fibrous cap through endothelial cell apoptosis and matrix metalloprotease production that may lead to plaque rupture. Of note, the effect of the vaccine are the opposite, with the induction of anti-inflammatory cytokines such as interleukin-4 and interleukin-10. Consideration around respiratory tract infection and cytomegalovirus are more or less the same. There are some peculiarity. For example, the Streptococcus pneumoniae is involved in a peculiar kind of inflammatory cell death that is called cardiomocyte necroptosis, and also platelet can recognize through toll-like receptor 2 antigen from Streptococcus pneumoniae with increased platelet reactivity. Also in this case, the vaccines have demonstrated beneficial effect, particularly in the elderly. Cytomegalovirus as well can induce direct endothelial damage through the inhibition of nitric oxide production, and also through direct effect on the endothelial cell with an increased relative risk of cardiovascular disease that is even higher with active infection. And then let's come to COVID-19. Atherosclerosis and COVID-19 show bidirectional association. Patients with cardiovascular disease are at increased risk to have infection. This is at least in part explained by the endothelial dysfunction that this patient have. The virus use ACE2 to enter the endothelial cells, and the infection produces a powerful inflammatory response with the release of cytokine, activation of a complement and coagulation cascade, and derangement of the local renin-angiotensin system with vasoconstriction, microvascular obstruction, and eventually multi-organ failure and local ischemia. Sorry. On the other hand, patients with COVID-19 experience high risk of cardiovascular events, meaning myocardial damage, myocarditis, but also acute coronary syndrome, not only the acute myocardial infarction from plaque rupture, but also Minoka, Takotsubo syndrome, and also arrhythmias and heart failure. And of note, asymptomatic patient may also have cardiac damage that can be also seen in cardiac magnetic resonance after 3 months from infection. And let's come to the world of bacteria. There are lots of infection, but I have no time. Just this slide, just to keep in mind that not only infective pathogens, bacteria, but also the colonizing flora can induce chronic low-grade inflammation, and potentially atherosclerosis. So this is the case of gut microbiota that can indirectly induce chronic inflammation, and also with some catabolites such as TMAO that can activate platelet and induce pro-inflammatory response. Our group demonstrated the presence of microbial DNA in the epicardial adipose tissue of patients with acute coronary syndrome, together with the elements of NALP3 inflammasome. Moreover, in another study, we demonstrate the presence of a clonal T-cell expansion. With an in silico modeling, we discovered a putative antigenic sequence for these cells, and we found up to 80% similarity with bacteria such as Firmicutes and Cyanobacteria that are normally in the gut microbiota. So, to come to conclusion, now we have strong evidence demonstrating the role of immune response in atherosclerosis. And we know that infection may interact acutely, chronically, directly or indirectly on the immune system. But we have less strong evidence on the direct role of infection of the disease progression on atherosclerosis. In other words, we don't know if it is the microbe itself or the huge amount of pathway activated from the pathogen that lead to atherosclerosis. To answer this question, we need surely large, well-designed studies. In the meanwhile, the promising field is that of vaccine, not only vaccine for a specific pathogen, but anti-atherosclerotic vaccine which target more pathways involved in this residual inflammatory risk. Thank you for your attention.
Thank you, Daniela. This was really a very, very interesting, and you have done some very interesting work on this specific topic. I guess that if there are questions, you'll be willing to answer, even if it was the opening. Is there any question? Thomas.
Just a minor comment. You mentioned CMV as a factor for inducing also the inflammatory response. How can you measure that? Because usually all of us have contact with this latent virus, and we are all having always contact with CMV virus. Was this acute CMV infection, or was it just the presence of this latent virus which we all have in ourselves?
We talk about the cytomegalovirus, right? Okay, these data are about different meta-analysis. Actually, we can say that with the active infection, the risk is even higher. But not only. We think for every virus, especially for virus, that this is just a stimulus to incite the process that then go on its way without the infection. This is not only for cytomegalovirus, but also for other viruses that has shown the same pattern. An example is HIV, another virus that can be latent, and in that case there is a strong correlation of atherosclerosis, but is related to lots of other things, of other stimuli. That's why we need to not to target the pathogen, but we need to target the pathway.
But that would also induce that we have similar effects with the other alpha herpes viruses. Because this is like the varicella zoster virus, like the herpes simplex virus, like the Epstein-Barr virus, because they all have the same feature that they maintain in our body as latent viruses.
Yes.
I have one question related. What I was impressed by the list of pathogens that you mentioned, such as Helicobacter, periodontal, cytomegalovirus, which are all also involved in the dementia issue. And I'm wondering if you would cross a bit your research with the neurological field, if this would help to disentangle the role of vascular dementia versus Alzheimer, which is more related to herpes simplex, and if there is any research ongoing on this field.
There's a lot of research about this, but also there are several intersections of this kind of aspects with all the with all the pathology, which includes a chronic, low-grade chronic inflammation inside. And it's very, very a huge amount of literature on this aspect. And also for Helicobacter pylori, for example, there are different outcomes coming from different parts of the world, explaining how therapy of this pathogen, eradication of this pathogen, may really influence sometimes the outcome, also in the sense of cardiovascular disease or in other direction.
Yeah. What impresses me is the fact that, for example, Helicobacter seems to be involved in so many, lymphoma, dementia, cardiovascular disease. So there must be some common pathway beyond all these chronic diseases that are related to these infections. Yeah. Thank you very much. So I would turn, if there are no more questions. Oh, sorry, I didn't see.
Yeah, just a short one. Now regarding the SARS-CoV-2, you mentioned that, as we all know, it enters through the A2 receptor. Many older people have A2 receptor antagonists, and I know there are data, if you stop them, that the course of the disease seems to be not so hard. How is it when are there data, and do you know if they take sartans instead of A2 antagonists as a model?
Really, actually, there are no definitive data about this, because during COVID pandemic, everyone did sometimes, in some cases, has been proven also a positive effect while maintaining the therapy with ACE inhibitors. We really need a good, well-defined trial or a study to assess the effect of this virus for what concern the therapeutical aspect. In cardiovascular, not only elderly people, but also in cardiovascular disease, ACE inhibitors are the main, are the bigger part of the therapy for heart failure and for myocardial infarction.
And my second part of the question, do you know if there are already comparisons, do you change to sartans instead of H2 antagonists?
At first, the idea was to change to sartans, and this is what have been done. But for the now, I think that around the mechanism there are several translational papers questioning this shift, because there has been proven also beneficial effect of the ACE inhibitor drugs.
Thank you.
Thank you, Daniela. So now I would turn the floor to Fiona for the next session.
Thank you, Stefania. So now we're going to look at the effect of influenza vaccinations and the relationship with cardiovascular and neurovascular pathologies. I think that it comes as a surprise to many people that the effect of influenza vaccination for cardiovascular patients can sometimes be of the same magnitude as some of the standard preventive therapies that are introduced, and I don't think that it has entered the common paradigm that it should be among the things that you always recommend to your patients, that they should get the influenza vaccine every single year. It's as important as many of the other therapies that you're going to ask them to take. And as a lifestyle modification, you're going to ask them to change their diet, you might ask them to, do a bit more exercise, but I don't think that it's in everybody's usual set of tools to tell their patients that they need to get vaccinated. I think that's something we need to work on. So now we're going to listen to Tor, who's going to tell us about the effects of vaccination, and then we'll hear from Nicola by his recorded presentation. Thank you. The floor is yours, Tor.
Thank you so much, Fiona. And it's become quite an easy task, following such a comprehensive review of how it actually affects the cardiovascular system. So thank you so much for taking us through that in the previous presentation. And I've been given the task to talk about influenza and cardiovascular outcomes, and also the role of vaccination in that setting. This is my disclosures. So, as we already heard, this theme has been a theme that has been done research in for several years, and I think it's actually during more than the last 20 years. Several studies have linked influenza infection with increased risk of stroke, heart failure, and acute myocardial infarction. And I'm going to take you through some of these case examples who have provided us with that knowledge within the last 30 years or so. Actually, this information already came about many years ago, almost 100 years ago. Dr. Collins and colleagues looked at this, looked at the association in a time series analysis where they found that up to 46% of excess death credited to what they called organic heart disease corresponded in time with the influenza peak season for practically every epidemic. So they saw an association between increased cardiovascular mortality and peaks in flu incidence. Exactly the same analysis, just repeated, 80 years later, found the same association. So despite the fact that we now have vaccines, we still see this very tight association between emergency department contacts, this is specifically in New York City, and a spike in daily cardiovascular death counts. In this time series analysis, this just published in 2016 compared to 1936, which the previous publication was from. More recently, authors in this study assessed whether patients who admitted to hospital with a positive flu test also experience cardiovascular outcomes during the same hospitalization. And as you can see, this risk of cardiovascular complications while being hospitalized for the flu. Interestingly, they saw that there was a different distribution of these specific cardiovascular complications depending on age. They saw that the older the participant or patient was when they were hospitalized for the flu, the higher the risk they were of being admitted for acute heart failure or ischemic heart disease. However, the younger patients admitted with flu had a higher risk of experiencing cardiogenic shock, acute myocarditis, or acute pericarditis. Looking specifically at acute myocardial infarction, Kwong and co-authors published this self-controlled case series analysis back in 2018, and this design is quite intriguing because you use the person at their own control, so you don't worry about external confounders. You can worry about confounders that change during time period, but you are comparing the person to themselves and just comparing the risk of having an event depending on different time zones. So they want to assess whether the risk of an acute myocardial infarction is higher in the vicinity of when you're tested positive for a flu, when you have a positive flu swab. And that's what is entailed in the self-controlled case series analysis. They found that within the first 7 days following a positive flu test, the risk of experiencing a myocardial infarction was 6 times higher than any other time point for the participants that they included in this study. Really showing the link between getting infected with the flu and experiencing a higher risk of myocardial infarction. If we look to stroke, other authors already back in 2004 did exactly the same analysis, a self-controlled case series analysis, but instead of looking at flu swabs, they looked at respiratory tract infection, so it's a less specific exposure variable, and they found that in the first week after a positive respiratory tract infection, the risk of stroke was approximately 2.5 times higher. So both for flu and both for acute myocardial infarction and for stroke, we have quite strong evidence that the risk of these ischemic events increases in the vicinity of a positive test. So that was stroke and acute myocardial infarction. What about heart failure? That was the last cardiovascular outcome that I mentioned in my introduction. I would show some evidence for. In this time series analysis, authors from Boston assessed the association between influenza-like illness and hospitalization for heart failure. They found that influenza-like illness was temporarily associated with increased risk of being hospitalized for heart failure, and for every 5% increase in influenza-like illness was associated with a 24% increased risk of heart failure hospitalization. This again is a time series analysis, and the interesting thing is that they actually saw a closer association in this time series analysis between influenza-like illness and heart failure hospitalization than influenza-like illness and acute myocardial infarction hospitalizations. So the first part of this talk, I took you through some of the case stories that have provided us with evidence that there's a link between getting a flu infection and the increased risk of cardiovascular diseases. What about flu infections in patients who already experience cardiovascular disease? In this present analysis, authors looked at the influenza or the influence of influenza infection on in-hospital acute myocardial infarction outcomes. So it's patients who are admitted with an acute myocardial infarction. They identified close to 2.5 million patients who were admitted with an acute myocardial infarction. Of these, approximately 3,000 had also a positive flu swab during that hospitalization. And actually, for all the outcomes that they assessed, they identified that if patients also had a flu infection, the risk of readmission, or I can't see, is it, sorry, no, the slide is so small. The first upper quadrant, it's readmission, right? Or restenosis, maybe it is, in the, yeah, sorry. But for all the major outcomes, also in hospital mortality was significantly higher for those who had a flu infections while they also had an acute myocardial infarction, and length of stay and also cost of their STEMI hospitalization. So all events seem to be more severe when you have a flu infection while you're being admitted with your acute myocardial infarction. For heart failure, exactly same kind of analysis. In this study, the authors looked at 8 million, close to 8 million hospitalizations for heart failure. 54,000 of these also had a positive flu infection while they were hospitalized. And as you can see, for regardless which outcome they assessed, in hospital mortality, acute respiratory failure with needing medical ventilation, acute kidney injury needing dialysis. All of these outcomes were significantly worse in patients who also had a flu infection. So can we prevent some of these events if we vaccinate our patients with cardiovascular disease? We actually have quite good evidence with it in this theme because we have 2 large-scale outcome trials testing exactly this question. We have the IVVE, which is a trial randomizing 5,000 patients with heart failure to a flu vaccine or placebo. And then that was on the left, sorry, and on the right we have the IAMI trial that randomize patients with acute myocardial infarction to a flu vaccine or placebo. I'm quite surprised that they actually were approved by ethical committee to execute these trials, but apparently they were. So if we start with the IMI trial, it was published in 2021. Unfortunately, the first thing you have to be aware is, oh sorry, the pointer doesn't work on this screen. But the first thing you have to be aware is that the trial was stopped early. So they planned to randomize 4,400, but they stopped that trial early and only managed to randomize 2,500. But regardless, they saw a significant risk reduction corresponding to a hazard ratio of 0.72 for the primary outcome, which was all-cause death, MI, and stent thrombosis at 12 months. So this is randomized data showing that a vaccine in patients being admitted with an acute myocardial infarction significantly lowers the risk of these cardiovascular outcomes. That also led to the update of a meta-analysis that was published many years ago in JAMA after the IMI trial. As you can see, just the IMI trial, which was, the first author was Ole Frøbert. That study alone, despite being underpowered because it was stopped early due to COVID, it is larger than all the previous trials conducted on this topic, comparing placebo versus a vaccine for cardiovascular outcomes in patients with acute ischemic heart disease. But it actually found an absolute risk reduction of 4.5%, meaning a numbers needed to treat to prevent one cardiovascular death of only 23. This is the most recent meta-analysis that we have on this topic of flu vaccines in patients with ischemic heart disease to prevent cardiovascular outcomes. So the IVVE trial that I showed on my previous slide, it was the 5,000 patients with heart failure being randomized to a flu vaccine or placebo. It was published in 2022. And again, sorry, the slides are, it's quite small. I don't know if people in the back can see, but actually for the primary outcome, they didn't see a significant risk reduction. It showed in the table or you know, on the left with the right line. The p-value is 0.30. So they didn't show a significant relative risk reduction of the primary outcome. However, they had a pre-specified analysis saying that we want to assess whether the vaccine versus placebo in patients with heart failure significantly lowers the risk of a combined outcome of cardiovascular death and non-fatal and fatal myocardial infarction in the flu season versus without, you know, outside of the flu season, which most flu vaccine trials, you know, do. Oh, sorry. And as you can see, for that pre-specified analysis where they only look at events that was captured within the flu season, which makes sense if it's the flu that caused the event, they actually saw a significant relative risk reduction corresponding to a hazard ratio 0.82 for lowering the primary outcome. So if you only look at events within the flu season, a flu vaccine significantly lowers the risk of this combined outcome. And as you can see for the secondary outcomes for all-cause death, cardiovascular death, they are actually also significant if you just look at the effect during the flu season. As you can see, there's absolutely no effect on any of the outcomes if you look outside of the flu season, which makes sense for a vaccine. So that is why we have consistent recommendation for influenza vaccination in patients with cardiovascular disease from all of our major societies. Now we've talked about patients who actually have an adverse cardiovascular disease, right? Acute myocardial infarction or heart failure. What about our risk factors that are much less severe? For example, hypertension. We know that patients with hypertension have an increased risk of death of cardiovascular causes, particularly from stroke and acute myocardial infarction. Do we know anything about flu vaccine in this group of patients who do not have a cardiovascular disease underlying? And actually, in the current recommendations for patients with hypertension, the flu vaccine is not mentioned anywhere. So it's not recommended for patients with hypertension only. Of course, if they have other diseases, then they can be liable to get a free vaccine. And in Denmark, specifically, hypertension as the sole disease is specifically written. You shouldn't provide a flu vaccine to patients with only hypertension. So we wanted to assess whether there's any evidence using the Danish nationwide registries, where we identified a little more than 500,000 Danish citizens over 5 seasons. This is retrospective, it's not a randomized trial, to assess whether a flu vaccine potentially lowers the risk of cardiovascular death and death due to stroke or AMI. As mentioned, a little more than 500,000, as you can see, for all of our outcomes, both all-cause death, cardiovascular death, and stroke or AMI death, a flu vaccine seemed to lower the risk of these mortality outcomes. Of course, again, retrospective. This is not randomized data. What about diabetes? We also know, just like hypertension, that diabetes have an increased risk of death of cardiovascular disease, particularly from stroke and AMI. We did exactly the same analysis, looking at patients who are purely diabetics. They do not have any other diseases that give them an indication for a flu vaccine. We identified close to 250,000 Danish citizens over 9 flu seasons, and saw that those who received the vaccine versus didn't receive the vaccine had a significantly lower risk of all of these cardiovascular mortality endpoints. So we know now that both from randomized trials and observational data, flu is associated with increased risk of cardiovascular outcomes. We know that a flu vaccine prevents cardiovascular outcomes for some diseases from randomized data, from other diseases just from observational data. But we have a really big problem with the fact that vaccines are not being implemented in the society. This is just data from Denmark, just showing heart failure, atrial fibrillation, ischemic heart disease, and stroke, and then stratified by age group. The elderly, we see an okay vaccine uptake, right? 60, 50%, but for the young people who suffer these diseases, the uptake is terrible. It's close to 20% from some of these diseases that have a median 5-year survival of 50%, right? It's quite crazy that we don't see a high uptake in these chronic diseases. That's why we executed a trial called the Notch Flu Trial, which we published last year, where we want to assess how should we inform the public about the importance of getting a flu vaccine to increase vaccine uptake the most. We randomized all Danish citizens 65 years and above to receiving either usual care or 9 different behavioral informed letters, which use different behavioral theories to see which kind of letters should we send out to the general population to increase vaccine uptake the most. The primary outcome was just whether a person received the vaccine or not. This is just to show the different letters that we tested. We, and I'm going to get more into detail with some of the letters in the next slide. And then we followed our population to see whether we increased vaccine uptake, but we also followed them through the flu season to see whether a change in vaccine uptake translated into a change in clinical outcomes. This is to show you the letter. So this is the template. The only thing that we changed within the letter was within this placeholder for text-based nudges. That's the only thing, the sentence that we changed in this randomized trial, right? So we only changed one sentence. Otherwise, the letters were completely the same. This is just to show you 3 of these 9 different behavioral nudges that we tested, and I'm just going to read out the top one. That was the cardiovascular gain one, because we're talking about cardiovascular system and flu vaccine. So in that letter, we wrote, in addition to its protection against influenza infection, influenza vaccination also seemed to protect against cardiovascular disease, such as heart attacks and heart failure. That was the cardiovascular gain. And here you can see the study population. 500,000 were randomized just to the usual care, not receiving a letter for us. And then you can see approximately 50,000 were randomized to each of these different letter arms to see which letter could potentially increase vaccine uptake the most. We saw 2 of our 9 nudge strategies that were efficient in increasing vaccine uptake. One was just sending out a repeat, where we didn't state anything in the placeholder, just sending a reminder twice about now it's the vaccine season. But very interestingly, especially for us as cardiologists, we saw that the most effective of all our nudging strategies was the cardiovascular gain framing letter, explaining the Danish citizens that getting a vaccine not only protects against the flu, but potentially also protects the cardiovascular system. We, of course, assessed whether there was any effect modification, whether there were any subgroups that benefited most from such a letter, and we saw that the most vaccine hesitant, those that didn't receive a vaccine the previous season, were the group where we saw the greatest effects. For those, we saw an increase in vaccine uptake close to 2.5%, whereas for the general, it was only close to 0.09%. As mentioned, we also followed these inhabitants in the registries for a longer period of time, assessing whether we could change clinical outcomes with an increase in vaccine uptake. But the vaccine uptake was so little, it was only 0.89 percentage point, that none of these letters significantly changed the trajectory of clinical outcomes for any of the Danish citizens. But we, as mentioned, we saw that the most vaccine hesitant were those that gained the most, because we increased vaccine uptake with 2.5% in this group. And interestingly, we actually saw that in this specific subgroup, we did see a significant lower risk of being hospitalized for heart failure or cardiovascular death. But of course, these numbers are so small, and it was a subgroup, of course, of a trial of 1 million citizens, but still it wasn't designed to assess this specific subgroup. Looking specifically at patients with the previous MI, we also published that subgroup very recently, where we saw that sending the cardiovascular gain letter to people who already are sick with an ischemic heart disease seemed to be numerically better, but there was not a significant effect modification. So despite seeing a 2.5% increase in this specific subgroup, we have to be aware that the effect modification wasn't significant. There was not a significant p-value for interaction. We also assessed whether our nudging letters potentially were better in patients with heart failure, and again, we actually didn't see an effect, and interestingly, we saw that for those who had a history of heart failure, our cardiovascular gain letter actually seemed to be less effective. Again, there was not a significant interaction p-value, but if you look at the bottom row in the forest plot, you can see that numerically it seems as if those who take most of the medication, who get 2 or more heart failure medication, had a greater numerical effect of getting nudged with the cardiovascular gain letter than those who didn't take heart failure medication. So maybe people who are more adherent to heart failure medication, currently we give them 4 types of medication, that's a lot. They also seem to be more nudgeable if you inform them about the importance of getting the flu vaccine. So what are my take-home messages? Influenza infection has been found to be associated with increased risk of cardiovascular outcomes. Patients with cardiovascular disease who are infected with influenza are increased risk of cardiovascular outcomes. Data from randomized clinical trials and observational studies indicate that influenza vaccination reduced the risk of cardiovascular outcomes, even in patients only with cardiovascular risk factors, that was the diabetics and hypertensives. Despite broad guidelines and professional society support for influenza vaccination in patients with cardiovascular disease, rates of vaccination remain suboptimal. Novel implementation strategies are needed in order to ensure that high-quality cardiovascular care, which includes promotion routinely yearly influenza vaccination. Thank you so much for the attention.
Great, thank you, Tor, for that very interesting presentation. Does anybody have any questions? Yes.
Thank you so much for this excellent presentation, and I was absolutely impressed by your data, which you collected over the period of time in Denmark, and I'm also always impressed by the high vaccine uptake in Denmark, which is above the WHO level, about 75% for the elderly. We in Germany, actually, we just reached 42%, something like that. So it's really, my question is, what advice could you give us to increase vaccination uptake. You have shown some features which could improve vaccine uptake, but I think it's a long way, and it always takes time until you really can improve vaccination uptake. And it's fantastic how you manage that.
So, first of all, I'm a cardiologist, right? So but I do research in this specific topic, and what we learned, at least from our notch studies, notch flu studies, we actually did 2 more. I just showed you the oldest of our notch trials. We've seen in the younger population where we see similar rates of vaccine uptake, 30 to 40%, that I showed you, the ones who are younger than 65 years of age. And there we see a huge increase, 15%. So here we saw an increase of 0.89 for the most effective notch. In the notch chronic trial that we executed this year, we saw an effect of close to 15%. And that tells us that just informing people through letters like this, remember, the usual care arm is actually, they're also receiving a letter just from the public, from the health authorities, right? They don't test any notching sentences, but our baseline letter was designed through the letter that the health authorities use. So one major recommendation is, informing everyone with a potentially, electronic letter or text message, because we've learned this year from the notch chronic trial where we randomized a younger population who don't receive that letter. Just sending out a letter in itself significantly increase, uptake. That could be a solution, at least, to increase uptake significantly in a large country like Germany. Then we also, of course, learned that despite the fact that just sending out a letter informing that, you are liable for free vaccine because you are older or you have a chronic condition, that some of our notching strategy seems to be more useful. Again, the cardiovascular gain, so putting fear into people about, the potential effect actually seemed to be an effective notching strategy to increase uptake the most, and we see the same effect. And then a reminder, the same 2 notch strategies that were effective in our older population seem to be effective in our young chronic disease, population as well. And I think if you ask about with the health authorities about why we see such large vaccine uptake, they argue at least that the trust in health authorities and politicians, and they link it a lot to trust in systems for why the Danes are being vaccinated in those high rates as they are. But we can do better, and I think these notching strategies, to test them is an important topic. We of course have an electronic system, the e-box system that we use for these electronic letters, but it can be done on text messages. We, at least in the country, we get alarms if there's some kind of natural catastrophes happening. You can use those kind of systems that I know they also have in the US. But that are at least my experience from doing these studies.
Great, thanks. Jane, you have a comment?
Yes, thank you. Terrific work. I certainly acknowledge Thomas's comments. I'm not convinced that reminders are the single course. I think it's a collection, it's very situational specific, because reminders are used in many countries. Japan is a good example, and it certainly doesn't kick up. What's intrigued me is the social and behavioural drivers that you've used, and different language that people understand. They understand heart attack. They understand heart disease. I'm still unconvinced that the general population understands the value of vaccination, beyond. So I'd like you to comment on that use of the social and behavioural drivers, and whether you're going to be doing any more work in this area. Because I think governments do not invest in this particular area. They invest in funding vaccines, but they don't necessarily invest in expanding pathways, simplifying pathways, etc. I'd like your comment on that.
No, I agree completely that, you know, from these studies that we executed, we can only, because it's randomized, right? So we can only comment on whether adding the different sentences work. You know, a very important learning point was also, for example, one of our letters, and remember, more than 50,000 Danes received that letter, was, you know, a health authority like the Fauci in the US or whatever, recommends, and that had no effect at all. You know, the fact that also not just that has been shown to be effective in other scenarios, the gain framing or, you know, the collective goal, they didn't seem to, and that might also be the fact that we came out of a pandemic, right? You know, where that has been how the health authorities, at least, they have been on TV so many times, you know, don't protect only you, protect your, you know, your grandparents, and so that might be the reason why it's less effective. And regarding your question about, you know, the continuous research, yes, we did a notch flu 2 testing the positive notch, so testing whether it makes sense to keep on notching the population year after year, right? Because that's also important if you want to implement this for the health authorities. And we saw that the notches were still effective. The same notches that we tested last year were the most effective, the reminder and the cardiovascular gain framing. Because we saw the cardiovascular gain framing, which was quite, you know, surprising for us. It was the only notching theory that we didn't take out of a behavioral science notching book, right? They had described all of the other 9 or the other 8 notching theories, but because we saw that was effective, we thought, okay, is that specific, you know, for fear of cardiovascular events? So we added a pneumonia, you know. Yeah. You don't only, you know, protect yourself against the flu, you also protect yourself from being hospitalized with a severe pneumonia or going to the ICU. And that wasn't nearly as effective as the, so it might be, you're right, that cardiovascular events, that's something that people understand and can relate to and fear.
Could I just have a quick follow-up question?
Sure, go ahead.
Look, I think also we've got to look at the structures in each country, because I understand that vaccination happens at a very local level, municipalities. So did the data touch on the social determinants, the socioeconomic, you know, advantage or disadvantage, and did you see any differences? Because we know that lower education, you know, impacts the uptake rate. So did you get a sense of that? I'm sorry, but this is really important work that you've done. No,
I agree, and it's I agree completely, and because that data, we have that data, right? We have educational level on everyone participating in trial. We have income on everyone. We have distance from the closest vaccine clinic. We have all of these data, but that's in a different kind of data infrastructure. So we had to get that, and we just recently received some of that data. So that is, of course, a very important thing to assess, because I would imagine that we will see the social gradient, as we see in many other stuff, that it's those that are less, low education level, lower socioeconomic, where we see the potentially or possibly the lowest effect of getting, you know, this information. But that's very important, and I agree we have to assess that. And again, we have at least continued to do it, this trial, modifying slightly the notches that we test, and then again extending it to the younger population, because we saw that, as you mentioned, Thomas, that 80% got a vaccine in Denmark, in that the 65 and above. So there's not a lot of room to notch, right? When the baseline is 80%, you're fighting, and you want to. So there's a much bigger gain in the younger with a chronic condition, where it's only 30 to 40%, where we saw this huge increase in vaccine uptake. So, no, you're welcome.
I'm always in admiration of Scandinavian countries and how much data they can collate about their populations and how easy it is for you to get access. We dream of that in France, but it makes it much easier to follow the events and to have an idea about the background of who's getting vaccinated and who isn't, and also then to know whether they have been vaccinated, because you're nudging people, or you may want to apply vaccination in the patients in your unit and they can't remember, and there's no way of finding out whether they got the vaccine already or not. So I'm always in great admiration of Denmark and your quality of the data that you produce. I think we have more questions. Marco?
Yeah, thank you very much. I agree that it was terrific work, fantastic. I would also like to back up the previous comments saying that we've done something smaller but similar in our region in Tuscany in Italy, randomizing nursing homes and sending either a nudge letter or reminder letter, just a normal reminder letter, to personnel working in nursing homes that could have been either healthcare workers or not healthcare workers, and either receiving a nudge letter reminding that the vaccination was free for them and protecting not only them but also the family and the people they were assisting. Basically, it didn't have any effect. So I think, well, I mean, the studies are different, of course, and some limitations might have to be acknowledged, but I think you really had an impact on different ways, on different types of things in the population, and well, it also highlights how good was the work, and probably how good was the design of the letters, how studied was. We're going to repeat it next year and see if things change, but this was the first result.
Great, and Marco again.
Yeah, the other Marco. So this is really interesting data, and if you look at the paper from Freubert, where they gave a flu vaccination during STEMI, do you think that's really flu specific? So, or is it just anti-inflammatory?
You know, I agree completely that the IMI trial is quite surprising. Yeah. Because, you know, and that's also why I wanted to underscore that they only recruited half of what they planned to recruit. They stopped it, you know, not because of any interim analysis. They just stopped it because of difficulties during the COVID pandemic, right? Yeah. And we know that underpowered trials, there's a great risk of them being over-optimistic, because they saw a reduction on cardiovascular death. There's not a lot of cardiovascular medications that reduce the risk of cardiovascular death in that specific population. So I think it's a chance finding. Luckily, it's the right direction, so we can use the data also to underscore the importance. But I think it's over optimistic. I don't believe that we'll, if we did a sufficiently powered trial,
that will be the same.
No, but it is so important that they did that study, and they didn't power it for cardiovascular death. Of course, the primary outcome was a combined. But you know, I'm very happy about that study. But I'm not sure that we understand the whole, you know, the mechanisms of how, whether whether it's just so underpowered that we see the trends that we see. Yeah.
Okay. Yeah. And so most of that research is all flu focused now, huh? But there's also data showing that RSV might even have a worse effect on cardiovascular health. Do you think that would add on that the patients you actually target get a little bit tired of all those different vaccines? Would that be a challenge?
That's a great point, and I'm not, you know, I'm a cardiologist, so I'm not an expert in, you know, I never actually administer vaccines myself. I just, you know, ask people to go to get vaccinated. But I think that's a really great point now when we have also a vaccine for RSV besides COVID, right? But I guess a lot of the companies are working on combining all of these, just like we do poly pills in heart failure. Heart failure, they're taking 4 medications. That's the ground pillar there to take that, you know, to improve prognosis. So I think we should probably think of poly vaccines as just like the companies already are now. But yeah,
thanks.
But it's only once a year, right? So it's much less than all the other stuff that they take every day.
That's true. No.
Yes, Dr. Gravenstein, go ahead.
Fabulous data. I love the way you guys have approached this. A couple of different questions. I didn't catch, you said you thought vaccine fatigue might be an issue in uptake. Did you measure how many prior vaccines they'd gotten in the last year or two?
So in the NOTCH trial, we just assessed whether they got a flu vaccine the previous season. We haven't done the sum of vaccines.
Yeah, so it might be an interesting question to say, did they get 2, 3, 4 vaccines? Because you have it in your database,
exactly.
COVID or something else.
Exactly.
And it's sort of two parts of this. One of them is vaccine fatigue, which is what you were suggesting might play a role. And the flip side of that is vaccine acceptance. So if it turns out that the reason that the nudge isn't working is because of fatigue, it might work a year later.
Yeah.
And if the reason it's not working is because they're not accepting, it may never work.
Yeah.
So it's something you might be able to nuance from your data.
That's a great point. And as mentioned, we only for our what we call the vaccine hesitant, it's only when they received the vaccine the previous season. We see the exact same effect modification this season, doing the exact same. Those that didn't receive the vaccine last year are those that we see a greater uptake when receiving the cardiovascular gain.
In our nursing home studies, we do see a spillover in the people who have low vaccine uptake for one kind of vaccine, they'll have the same low uptake for others. There's a second sort of factor to this, and that is there's a spillover in the vaccine uptake by the staff who administer them. The staff who have low uptake themselves also don't do as good a job in getting uptake in those people. So there's another piece to this. A second question I have for you is the construct of doing this in Denmark and whether you think the same set of questions would get a different result in a different culture society. So in an Asian society where people live at home much longer, if there's a different kind of shared accountability and an argument about you're doing this for your family might play differently. Or in a place like in Eastern Europe where the trust of doctors is less, the nudge to say that you should be doing this, for whatever might. I think it would be interesting to know.
Yeah, and I agree completely, and that's also what we discussed just before, right? That it is, I think, and Thomas also asked about this, how come we have such a high vaccine uptake? I really believe, or at least that's what the health authorities tell us, that the trust in the authorities, trust in our politicians, which probably is also combined with the very low corruption and so on in our structure, is potentially a reason why we see the results that we see in our NOTCH trials, and that's why it's so important to do it multinationally with multicultural inclusion, because that would really, then we could tease out the effect modification that potentially exists between the societies. But yeah.
A fascinating thing in the U.S. is that it's so politicized that there are folks who are vaccine hesitant, for example, for COVID vaccine. One of the reasons they use in the U.S. is because pharma is trying to make money. Yeah. Which is just.
Yeah, but it's. It's. I agree completely that has a huge effect of how you would, how you would think of when you receive such a letter from, a research organization as us, whether, I know that Fauci, he has to have security 24/7. So I sent this letter out to 1 million Danes. That's all Danes above the years 65 and above. I don't need any security in Denmark, at least, because apparently they are not feeling, threatened that I send out the importance of getting a vaccine, and that's just me as an academic researcher, right? So, yeah, I think there's definitely very big differences between cultures and countries.
And in line with what you were saying, I think ideally if we could recognize or identify what trigger or what nudge will speak to different groups, we could individualize it so that you would send the appropriate nudge to the appropriate group and send to them a message that will speak to them, because if they receive a nudge that's not pertinent for them, it's not going to work. So if we could know in advance who's susceptible to which message, that would be helpful. But I think that's in an ideal world.
Yeah, in our nursing home context, the nudge needs to be to the person who's giving the vaccine rather than the nursing home resident.
Well, also, yeah. Yeah.
Yeah.
Yeah, because vaccination among the professionals is a major thing, as was highlighted by the pandemic. But I think in the interest of time, if we have no more questions, we'll move on to listen to Nicola's presentation. Welcome, Professor Michel. You snuck in without being seen there.
I'm very sorry I arrived late, but I had exactly the same questions as Stefan concerning how the cardiovascular outcomes for one shot or several shots. But do you know how long will be the cardiovascular protection after one shot? 1 year, 2 years, or what are you thinking?
No, but I think that's a hard question, and I think no one has the answer currently. But if we just base it on the randomized data, and I would definitely prefer to do that, the IVE trial, showed quite clearly that that's cardiovascular outcomes, where they randomized 5,000 patients with heart failure to receiving a flu vaccine or not. The primary outcome was negative. They didn't see an effect when they just looked at the 3 years. I think 3 years follow-up was they had on the longest. But if they looked at events occurring within the flu season, right, then they saw a significantly lower risk of the combined MACE outcome, right? So I think from that data, I would say that it only protects within, but that's I guess the data that I would go to argue, but others have other, and I know that we ourselves had actually done a register-based study where we showed that the sum of vaccines there was a gradient, right? The more years you had received your flu vaccine, but that's observational data that is biased by confounding and so on.
But I think that's the biggest problem in large prospective influenza trials, right? So you will not know at forehand if the vaccine will match, but you also definitely will not know if it's a heavy season or not.
Okay, thank you everyone. Thank you, Tor, for the presentation and the great data. Shall we now listen to the presentation from Nicola?
Good morning, everyone. Thank you so much for the invitation to this meeting. Very nice and very important. I am so sorry not to be in person, but I have some familiar problems. So today I would like to speak about the very important hot topic about influenza vaccines, neurovascular disease, and particularly dementia. So practically we have some evidence, some literature overall reporting that influenza could be associated with various different neuropsychiatric disorders, including confusions and encephalopathy. But probably the most important known, I can say, association is the link between influenza and delirium that is of clinical importance. Moreover, it has been reported that the infection from influenza during pregnancy has also been associated with an increased risk of schizophrenia or bipolar disorder in the offspring. And then finally, I would like also to remark that we have an increasing body of literature, particularly from animal and in vitro models, that overall suggests that influenza could be a trigger for neuroinflammation. In this regard, this year, practically, this very nice paper was published about to think viruses as a trigger, practically, for Alzheimer's disease, dementia, but also, I can say, neuroinflammation more extensively. You can see that viruses can practically lead to increase the risk of Alzheimer's disease using several mechanisms. First, a direct neural infection. Let's think, for example, to encephalitis or meningitis. Probably the most known is the chronic neuroinflammation, and here, as shown very clearly from the figure, you have practically a contact between viruses and the activation of microglia and finally astrocytes. It should be said that probably this mechanism is probably the most known about the probable link between viral infection, including influenza and Alzheimer's disease. Some new literature also reported that the virus of influenza may impact on alpha A-beta processing and tau protein dysregulation, and we know, following the theory of amyloid beta plaque, that is a very, very important mechanism. Of course, other literature is urgently needed. Finally, we have other two possible mechanisms. One, immune system dysregulation, of course, because influenza is a viral disease, but also it has been reported that some epigenetics, sometimes some genetics modifications can finally increase the risk of Alzheimer's disease. Even if we can extend this opinion to practically to all viruses increasing the risk of Alzheimer's disease, I believe that influenza also for its epidemiology has a particular attention about this. However, to be honest, we should remember that practically the epidemiological literature associating influenza and the risk of dementia is probably less consistent than the literature about in vitro and animal models. For example, in this very, very nice paper published about 5 years ago, the authors included really a lot of people, of participants, as you can see from the slide, but the exposure to influenza in utero practically did not increase the risk of dementia later in age. You can see that the follow-up was particularly long, that the population was extremely large, but you are not able to see any significant difference between exposed and not exposed to influenza. And a practically similar point is reported in this very nice paper published in 2016, in which practically to have or not to have influenza practically did not modify your risk of dementia, and also independently for number of episodes and number of years since the last episode. So this literature practically is somewhat sad, I can say, about the possible link between influenza and the risk of dementia, but what are the possible reasons? One reason probably is that in these, of course, studies, influenza is mainly based on clinical diagnosis, and of course this is based on clinical signs and symptoms, and not supported by viral tests, serology, and so on. So practically, we cannot rule out the possibility that some recorded influenza diagnosis were not caused by an influenza virus, but for example, by some para-influenza viruses that could increase less the risk of dementia. Second point, really very important, is that practically in all these epidemiological studies, the diagnosis of influenza is made only in certified cases, and even if so for example, in one of the studies that I mentioned before, the sample size was very large. Again, probably we are still missing some cases of influenza, maybe the less severe, that however could increase the risk of dementia. And the possible other biases or other limitations that are not able to show any significant association between influenza and dementia in human beings. Probably this paper that was published the last year by the group of Professor Ferrucci and his collaborators in NEURO. It is a very, very nice paper, practically trying to explore the exposure to not only to influenza but to several viruses and the risk of several several neurodegenerative disease. And you can see from the slide practically influenza, particularly when you have some severe form such as pneumonia, were significantly associated with 5 among 6 neurodegenerative disease, practically supporting that the role of influenza could be important in increasing the risk not only of dementia but also of other neurological disease. And probably this is one of the strengths of this study is the fact that the diagnosis of influenza was mainly made using serology and other validated tests. What about vaccines? So the history practically of vaccination against influenza and the risk of dementia, in particular of Alzheimer's disease, so has about 25 years. This is probably the first study trying to explore the past exposure to vaccines and the risk of Alzheimer's disease. And you can see, for example, these authors found that past exposure to diphtheria or tetanus vaccination was associated really with a significant decrease in the risk of Alzheimer's disease, similar to the polio. On the contrary, they were not able to find any association between the vaccination against influenza and the possible risk of dementia. But finally, this is another most recent study. The interest about influenza vaccination and the risk of dementia was further explored by other studies. You can see, for example, in this very nice study with a very large cohort made in people affected by chronic kidney disease, that practically the risk of dementia in people undergoing vaccinations was really significantly lower compared to their controls in a propensity match score analysis. You can see that the effect was more evident in older people, in people older than 70 years in particularly. Moreover, that this is another important point, that the vaccination frequency reflected the protective effect against dementia during the influenza season. And another important point is that more doses you had in the past years, more effective is the effect against dementia. The same a similar finding was found in COPD. That is probably another important comorbidity present in older people. Again, when these authors compared people vaccinated against and not vaccinated against influenza, they practically found that the risk of dementia was significantly lower, of about 32% in people undergoing flu vaccinations. And you can see from the second part of the slide that practically you can find a sort of linear trend between the number of doses and the risk of dementia, practically indicating that the risk of dementia was significantly lower when you have more doses in the previous years of flu vaccinations. And this is a similar study, again showing this important concept made in a large veteran cohort, so practically in people having different disease and not also only COPD or only chronic kidney disease, but practically you can see that the repeated receipt of influenza vaccinations compared practically to people that decided not to go to a vaccination, that was a consistent part of this population. You can see from the slide is associated with a lower risk of dementia. And practically the authors conclude that these their findings are somewhat consistent with the hypothesis that the vaccinations may reduce dementia by training the immune system, as I mentioned also before. And of course, they practically suggested in their conclusion that if vaccines could be associated with a significantly lower risk of dementia, probably now we should think this as another intervention to try to decrease the risk of disease that unfortunately in these years we are not able to treat at all. In fact, to conclude this part of evidence, 2 years ago we published a systematic review and a meta-analysis published in Aging Research Review. Practically, as you can see from the slide, also adjusting after several confounders, practically, you are able to see that we found a consistent association between influenza vaccinations and a lower risk of dementia. Moreover, as you can see from the first plot, practically the first 3 studies made in Asia, the risk was practically similar, 0.67, 64, and 68, and only the last one made in Europe from Weinke practically moved the risk less consistent, increasing the heterogeneity. After our meta-analysis that, like to say, was really highly represented and well cited across the world, we had other studies practically confirming the importance to have not only vaccinations against influenza, but also to repeat, to continue vaccinations during different seasons. This is a study published in 2022, and practically you can see that influenza vaccination is associated with a reduced risk of Alzheimer's disease in a United States sample of older people. And you can see that people having 0 vaccination had unfortunately the highest risk, followed by those having 3 flu vaccinations in the previous years and or 6 flu vaccinations. Again, this study made in a very large populations, about more than 2 million people, practically confirmed a linear association between influenza vaccinations and the risk of dementia. And more recent, with the data of the UK Biobank, that practically include about 500,000 people with a very long follow-up of years and years, the authors found that the vaccination against the flu is really important to prevent the risk of dementia. And this effect was practically independent from several cofactors or moderators. For example, the effect was similar in people from 60 to 64 and those older than 65, between males and females, between people having or not comorbidities, and education, self-rating, and also the APOE4 gen type eukaryotes or carriers, as you can see from the slide. But practically, independently from this, it seems that this association was only statistically significant in older people, in people having more comorbidities, in people not carrying epsilon 4, and so on. Unfortunately, the authors have failed to find any significant association between flu vaccination and the risk of Parkinson's disease, and we know how important is Parkinson's disease in older people. And in my opinion, this kind of literature merits further exploration by our sites. But why influenza vaccinations could prevent practically the risk of dementia or Alzheimer's disease in older people? This is a very nice study made in mice, in which practically influenza vaccinations in early Alzheimer's disease was able to reduce amyloidosis, and finally was able to ameliorate cognitive deficit in mice when compared practically to placebo or to the control group. And this effect, as you can see, for example, from the letters, from the graphs from the letter C to H, you can see that the effect of flu influenza, influenza vaccinations was very, very important in cortex, hippocampus, and so on. Practically meaning that probably, as I mentioned before, influenza vaccination was able to decrease the trigger of influenza infections. I would like also to remember that another important mechanism, at least in my opinion, is that influenza vaccination is not only able to prevent, of course, influenza, but seem to have a high number of pleiotropic effects. Since in this meeting we are discussing about cardiovascular disease, we'd like, for example, to remember that, as we showed some years ago, that practically influenza vaccinations was able to reduce the incidence of major cardiovascular disease in older people in several randomized controlled trials, as you can see also from the grade assessment, even if I should admit that the grade sensitivity of evidence of the grade was only low. And practically what we concluded in this review is that, of course, influenza vaccinations was able to decrease the risk of cardiovascular disease, but also exacerbation in COPD and other conditions that probably are able also to decrease the risk of dementia using an indirect mechanism. Finally, I would like also to remember that influenza vaccinations was probably able to reduce the risk of vascular events, and practically we have some very, very nice literature, as you can see, for example, from the figure, in which practically the influenza vaccinations was able somewhat to modulate the blood-brain barrier, and particularly to regulate the disruption of this kind of organ. It is very, very important because, of course, as you know, practically a lot of toxic toxins are able to pass from the blood to the brain, finally leading to dementia, and to have a mechanism that is able to fortify or to mirror, of course, blood-brain barriers is very, very important. However, so I should again admit that we are talking about in vitro and in animal models, very fascinating, but some data in human beings are finally needed. So I am going to conclusions, and I would like to conclude with this letter published in 2022 in the Annals of Medical Surgery, and I was really surprised because the first lecture I was saying, but it's not a journal dedicated to this kind of stuff, but also I remember to myself how influenza is also important in discipline other than geriatrics. Despite all the efforts, there is still a lack of efficacious interventions that we can offer today against dementia. So it is also important to remember that prior studies include a reduced risk of dementia in selected populations, including, as I show you, veterans, people suffering from chronic kidney disease, COPD, but also I can say today in general population, practically indicating that the epidemiological evidence between influenza vaccination and the risk of dementia and Alzheimer's disease is pretty strong. And probably the conclusions of this letter is of importance because vaccines are really inexpensive, and in diseases such as dementia, for which we don't have any restrictive mechanism or options or silver bullet, probably we should think that we can increase the coverage of flu vaccinations in order also to decrease the risk of dementia. Thank you so much for your attention, and I hope to see you in person very soon.
In the absence of Nicola to take questions, I'd like to open the floor for discussion and comment. Does anybody have any comments to make about the presentation? Go ahead.
Nice presentation, thank you. So you should know that I believe that infections are promoters of dementia, but still, one of the challenges with these observational studies is that dementia itself creates a collider bias for how these are assessed. And what I mean by that is that people who have early cognitive impairment or are frankly demented have an underlying risk of not getting vaccinated in the first place. So they get selected in a way that they're more likely to get infected and not vaccinated. A second thing is, and this is something that we published last year, in the nursing homes, certainly with COVID, we noticed that the people who have dementia have much worse COVID. And we think the reason for that is that people with dementia have behavioral changes where they do not know how to protect themselves from getting infected and isolate and other kinds of things. And what I'm trying to say here is the collider bias with dementia is for people who have cognitive impairment, they may have a higher risk of infection in other settings too, and therefore create a risk for infection that where they're more likely to have outcomes. So two things that make observational studies a little harder to evaluate, even though there's rich data to suggest that there's an effect.
Thank you. Anyone else? Yes, Jane.
Thank you once again, an excellent presentation. I'd just like to follow up on Professor Gravenstein's comments because I think that they're very relevant. The International Federation on Ageing did a study of 34 countries and policies specific to residents in long-term care. We looked at national ageing policies, we looked at NITAG policies, and we looked at policies across the associations and particular to providers. Not surprisingly, very little. And so this is a growing population with chronic comorbid conditions, including dementia, frailty, which are not being addressed by policymakers. And so if we don't have the policies in place, it's very difficult to get vaccines in arms. And historically, we know that the healthcare workers in long-term care facilities, also have extremely low uptake rates. So we're really, looking at not only a lack of policies and a lack of intention, but missed opportunities with this population.
That's a very interesting point you raised, Jane. So what's your position then on the ethical question of vaccine mandates? Because if you make people get vaccinated, that's one very effective way, either pending sanctions in the workplace, or you can incentivize them and give them a financial incentive to get vaccinated, or you can just tell them you have to be vaccinated or you lose your job. That can work in a short-term perspective, such as the COVID pandemic, where there is a public health scale imperative for mandates. But otherwise, how can you ensure that, for starters, there's political will to implement policies specific to nursing home residents, and also that there's political will to implement policies specific to healthcare professionals? What's your position on that?
I live in a country called Canada where the rights of each person are critically important and their human rights. I think my position is mandates don't work in the long term, right? That's it. But we also have a growing population with decision-making disabilities, and there are systems in place that support people of all functions to live the life that they have in front of us. So, entry point processes into long-term care is a very clear way of ensuring that, first of all, you have baseline data, but you also have the opportunity of a caregiver or an advocate to be in that process. I'm concerned that certainly in the global north, we have paid little attention to those who have significant loss of capacity or declining capacity in this whole conversation about immunisation, despite the evidence. Evidence is is not equaling uptake rates, or it's not equaling funding for vaccines for the latter half of life.
Would you agree that the evidence is such that we might be able to consider that vaccination is a low-cost intervention with negligible risk that we could maybe introduce into routine care, in which case you could use the opportunity of entry into a nursing home, for example, to say, well, this is what we do with our new residents. Everybody starts by getting their room and then getting a vaccine.
Look, the evidence is very, very clear. I mean, you're the experts. The evidence is clear. What I'm seeing is that we're not very good in creating the narrative and the business case for policymakers. You know, just because we have eminent academics and researchers, it doesn't mean that they're the same person that should be in front of a politician or a government advisor. It needs a collective. It needs the experts, but it also needs civil society, needs the scientists. You know, so we have to be thinking about how we can use this evidence to the best of our ability. This is about this is economics.
Yeah, I agree with this point that really we don't pay attention about how we present the narrative of the role of vaccine. And I was impressed by a psychologist who mentioned the fact that if you ever look through the recommendation in different countries, they usually say you should get vaccinated for flu because you can prevent flu, which is very dangerous. No one, or virtually no one, say you should get vaccinated because you are protected from cardiovascular diseases or the downstream factor. And this, from the psychologist's point of view, is the way you present the issue that has a completely different acceptance from the population. I'm wondering if in Denmark they focus the messages on this positive way that vaccine protect from cardiovascular consequences and so, instead of focusing on the fact that flu is a very dangerous disease. According to the psychologists, this is a major difference.
Tor, would you like to comment? I think you've already told us about the fact that the cardiovascular gain nudge was the most effective one. Do you think that's because it was a population of, no, it was a general population of all Denmark, so it wasn't specifically people who had any fear of cardiovascular disease or prior experience of that?
No. So in Notch flu, because we tried to assess whether there was any subgroups. That's why we thought that maybe people who already experienced, a cardiovascular event. That's the subgroup analysis has showed with specific patients who had a myocardial infarction before, and it seemed to be numerically more effective in people who already have had a acute myocardial infarction. But it wasn't, the effect modification wasn't statistically significant. So numerically, but, that could also just be a chance finding when we're going down in these subgroups. Of course, a subgroup of 25,000 because we're randomizing 1 million. But it's, and the interesting thing was that the heart failure population, there was a neutral effect, those who had heart failure at baseline for this specific notch strategy of linking flu vaccine to protect your cardiovascular system. But we again saw a numerical greater effect on those who were most adherent to the heart failure medication. And we already know that people who are not adherent to heart failure medication, that's the same people as Jane mentioned earlier, those who are less educated, those who come from lower socioeconomic status and so on. So I think we experienced the same socioeconomic gradient as we do in most of what we do in clinical practice. But again, it was effective in general in the population, providing some kind of fear. And the interesting thing is, and that's not published for this year, where we tested the cardiovascular gain notch against the long nudge, with creating fear about getting a severe pneumonia that was not at all as effective. I don't know why. I don't have the answer. And now we're also using, these, as mentioned, this kind of nudge was the only one that didn't come from nudge theories, and we beat all the behavioral scientists, putting in the cardiovascular gain nudge, and it seems logical for us, right, somehow that people, when you inform them about this association, that's been the strategy for a lot of our meetings from the last couple of years, that just informing people about this link is so important, that could potentially increase vaccine uptake. And in the nudge trial, we actually saw it happen, informing people themselves about this link.
I have a suggestion for your next round. You might like to try a dementia nudge, that getting influenza vaccine can prevent you against dementia, and then a joint nudge, cardiovascular disease and dementia prevention, might be helpful. Because I know fear is probably not an ethical technique, but it's the oldest technique in the book, and it works. So it might be worth exploring. Jane?
Oh, I think Cornell was first. Thank
Sorry,
you.
Cornell, go ahead.
Yeah, just more anecdotal, but just what you have just said, My experience with COVID-19 and vaccination in older people, so they often say, I don't want to be vaccinated. If I have a chest infection and I had a nice life, chest infection, the old man's friend. So if you tell them about cardiovascular disease, I think there is a certain hierarchy. Myocardial infarction, if you say, there are side effects like myocardial infarction, it doesn't work so well, because people think these days that you don't die and you get a stent and it's over. If you say stroke, it's already much more, because you are disabled. And if you come to the story of dementia, then you get them. So it's sad, but it's about people. They need to know the disease, and there must be the fear in it. It's my personal experience clinically.
Jane or Tor, would you like to react?
It was just a very short comment. I actually think that if you said that it could get cancer, then I think we would have an effective nudge.
Well, you'd think that, except that when you tell people that they can get the HPV vaccine to protect against all sorts of genitourinary and cervical cancer in particular, the uptake is still not great. So I'm not even sure that nowadays that would work. I think dementia works as in the long game for people who don't want to finish their life with 10 or 15 years of dementia. So I think it's playing on what they fear will happen to them going forwards.
Take for cardiovascular disease as a warning would be even lower, because it's just a very young group, right? So
Could I suggest that we turn it upside down? Because I'm not convinced that fear works. I think fear of having a heart attack, sure. But I think the whole health promotion prevention package is what governments are more inclined to invest in versus something else. But I would call on anybody to come forward with knowing public health messages from government that are talking about the benefit of vaccination with cardiovascular disease. Because I don't know heart health, I don't know of any public health agency that is doing that. And I'm not sure that Denmark is doing that. I mean, this is a really important study, but we haven't got to the public health agency saying, yes, this is our campaign. So we're kind of a bit away from it still.
I think we need more data on that. Yeah, Tor?
It's just as an answer to Jane's point, and I agree, I'm not aware. And the interesting thing is that, so the Danish Health Authority, those that actually, that could use the data from the nudge flu trial the most, because they are sending out letters. Despite the fact that they saw that the cardiovascular gain was the most effective, they haven't implemented, but they implement the reminder, just sending, neutral letters twice, because they fear that, it's too extreme, despite the fact that we see that we do not, decrease vaccine uptake, and that's the amazing. So they don't even rely only on evidence. There's more in the decision making of how they go about to, yeah.
And also, I think people are less inclined to rush out for a potential benefit that they won't see. whereas their fear that they may end their life with 10 years of dementia is sometimes stronger and will prompt them into action. It's hard for people to materialize a benefit that they think, well, I'm never going to get cardiovascular disease. Everybody thinks they're not, they're not at risk and that it's not dangerous. As Cornell said, people come into our unit with an acute STEMI and they get a stent and they're let out maybe the next day and they think they're fine. They think their counter has gone back to zero and they don't realize the importance of lifestyle, medications, vaccinations. So it's difficult. Different populations are susceptible to different messages. Should we wrap up there for this session? I think it's time for the break before we move on. Thank you everybody for the interesting discussions and thanks to our speakers, and we'll reconvene in like 15 minutes? Or
15 minutes.
Yeah? Okay, 15 minutes?
Yeah. It was Jean-Pierre Fall. Okay, so let's go back to our program, and now Thomas is going to present the pneumococcal vaccination in the elderly, prophylaxis beyond the pulmonary spectrum. Thank you, Thomas.
Thank you, Stefania, for giving me the chance to talk about pneumococcal infections, about pneumococcal vaccination in the elderly, and especially about its impact in the prophylaxis beyond the pulmonary spectrum. First of all, my potential conflicts of interest, just to show you that I've talked for several companies. And to start with, I would like to divide my talk in the first part to talk about the bug, the clinical features, and about the epidemiology. In the second part, I would like to talk about the available vaccines and its effect, also concerning the impact of herd effects and herd immunity. And then I would like to talk about the infection and cardiovascular events, and like to show you some studies with the impact of pneumococcal vaccine. To start with, I would like to introduce the bug to you, which is the pneumococcus. And we are aware that we right now have more than 100 serotypes. The serotypes are classified by the polysaccharide capsule, which is the outer surface of the pneumococcus. And that means that's also the main thing which we address if we give vaccines. We address directly the polysaccharide capsule. We know that this is also a pathological feature because it impairs phagocytosis, and strains without a polysaccharide capsule are non-virulent. The typical feature we associate with pneumococcal infection is pneumococcal pneumonia. And I would like to show you this clinical feature with a patient we've seen in our hospital. On the left-hand side, you see the patient when he entered the hospital. And he had this infiltrate, which you can realize. And we immediately started the correct antibiotic treatment. But 3 days later, without any change in the antibiotic treatment, you see that the radiological feature really had worsened. So that means if a pneumococcal infection starts, it's really very difficult to intervene in the sense that you can stop it immediately. It always takes time. Having a look at the situation in Germany concerning community-acquired pneumonia, in Germany, with a population of around 80 million people, we are aware that we have 200,000 hospitalized patients with a community-acquired pneumonia. The mortality is around 12 to 13%. That means we have 25,000 people dying in Germany due to community-acquired pneumonia. And if we realize that 40 to 50% of all pneumonia cases or episodes are due to pneumococcal bacteria, that means that in Germany we have around 10,000 deaths due to pneumococcal community-acquired pneumonia. What about the epidemiology? We are aware of data which have been also taken into consideration by the STIKO when they had to decide about pneumococcal vaccines, having in mind that there is a small peak around the first year of age, that means in infants. And later on, we realized that there's increasing numbers of pneumococcal infections in the age group 60, 70 plus, and so forth. But this is age-adjusted incidence of pneumococcal pneumonia. But if we look at the death rate, we must realize that it's really the peak burden is in the generation between 60 and 80 or 90 or even higher. That means the average number of yearly deaths due to pneumococcal meningitis, pneumonia, or septicemia is really in this age group in the generation 60 plus the highest. Even in the time of, or in the period of the COVID pandemic, we realized that the upper curve, which is the age group 55 plus, we always, usually in the pre-pandemic period, we had the highest peaks in wintertime, during wintertime. Then we had the number going down during the pandemic, but we realized that at least in the last year, we had a level which is really or nearly the same as in the pre-pandemic area. How does it all start? It usually starts with pneumococcal colonization, which is asymptomatic in the beginning, and we are aware that this is age-dependent. We have very high rates of nasopharyngeal colonization in preschool children, which is above 50%. We have still a level of 1/3 being colonized in the primary school, and that goes down in high school down to 25%. And we can continue that in the elderly, because if the elderly have close contact to young children, that means they have a higher colonization rate, which is around 10, 15, up to 20%. And in the elderly who have no contact with young children, the rate is below 10%, 5 to 10%, something like that. What does it all mean? We have different manifestations of pneumococcal infections in the age group above 50, which you can see on the right-hand side, compared to children and infants, which you can realize on the left-hand side. If you have a closer look on the data, and we start with non-bacteremic pneumonia, we can realize that more than 60% of pneumococcal disease is linked to non-bacteremic pneumonia. The next important step is bacteremia. That means generalized systemic inflammatory reaction, which is around 26%. We have bacteremic pneumonia, which is around 11%, and the lowest percentage is meningitis. During childhood, the most important issue is acute otitis media or sinusitis, and not as much as you realize as pneumonia or bacteremia. This is the pathogenesis, again starting with colonization with pneumococcal bacteria. And if they are able to cross the mucosal barrier, then we have two different ways how pneumococcal infection can start. The worst situation is the red block, starting with bloodstream infections, then finally leading to not only bacteremia and sepsis, but also to meningitis. And on the other hand side, the blue block is local invasion, and it means that leading to otitis or sinusitis, and also to non-invasive, that means in the beginning non-bacteremic pneumonia, which then finally also can lead to bacteremic pneumonia. Why is this important? And why is this important with these different colors? I drew that due to the fact that on the left-hand side, the available polysaccharide vaccines only interact on this red block, that means invasive pneumococcal infection, invasive pneumococcal disease. If we have a look on the conjugate vaccines, that means that we can interact, it interferes with colonization, and it can stop not only bloodstream infection, but it also can stop local invasion. So that means pneumococci are a typical cause of pneumonia, meningitis, bacteremia, and so forth. Pneumococci cause systemic inflammation and systemic infection, and systemic inflammation causes secondary disease and organ complications like cardiovascular manifestations, diabetes, renal failure, and so forth. What different types of vaccines do we have available? Starting right now with the polysaccharide, pneumococcal polysaccharide vaccine. That's the simplest way, that we take the polysaccharide of certain serotypes and let them interact in this vaccine and let them interact with the B cell. And that's a very good approach, that you can produce type-specific antibodies. But it also has certain disadvantages. It is T-cell independent. That also means that you have low or missing immunogenicity in children below the age of 2. You have no immunologic memory, and you have no interference and no influence on colonization with the vaccine serotypes. That's what I mentioned already in the slide with the pathogenesis. If we have a closer look on the vaccines, on the conjugate vaccines, we realize that you also use the polysaccharide, but that is linked to a carrier protein. And that makes it possible that not only the B cell can address this polysaccharide, but that makes it possible that also the T cell can help in the way that there is a memory response, and you do not only have an antibody production, but you have also a long-lasting memory response. So this has the real advantage and it's definitely the better immunological approach. It's T-cell dependent. It also has a good immunogenicity in newborns and in infants. It has immunologic memory, and it can reduce nasopharyngeal colonization. And that is also very important if we talk about these different vaccines which we have available. The oldest vaccine has been this polysaccharide, the 23-valent polysaccharide vaccine, which we now have nearly 40 years already in use. And then we started with a 7-valent, a 10-valent conjugate vaccine, then the 13-valent came up, and right now we have available on the market the 15 and 20-valent conjugate vaccine. And this is field still in motion due to the fact that some companies are producing or are developing right now a 21-valent vaccine, a 24-valent vaccine. So that means that there's still a lot of progress made in the last couple of years, which is still going on. And I think in the next 1 or 2 years, we will have some more vaccines available on the market. So this definitely also has an impact if we vaccinate as a basis strategies our newborns and our babies. That means, and that can be seen on this slide as well. On the left-hand side of this slide, you can realize some studies which have been conducted before the introduction of the vaccine, of the conjugate vaccine. And then the gray bar indicates the introduction of the vaccine, also showing you that the carriage rate went down from a rate of 30 to 40% down to 0 to 5%. That means you have an impact not only in the children, but they also spread the bacterium also to their parents, grandparents, and so forth. And that means you definitely also have a herd effect on other population groups which are not directly vaccinated. And that has been quite nicely shown that the conjugate vaccine in children has definitely also an impact on the elderly population. And here is quite nicely shown this effect for the 7-valent conjugate vaccine and the 13-valent conjugate vaccine. After 3.5 years, after 3 years more or less, you had a 50% reduction of these serotypes which have been incorporated in the vaccine, and you had a reduction of 90% after more or less 9 years. So that means very often this is the basic strategies also for immunizing the elderly to have a good vaccination program in young children. And a similar effect has been shown. The introduction of the 7-valent vaccine and the 13-valent vaccine, this is data from the US, definitely also showed that the invasive pneumococcal disease decreased in the elderly above the age of 65. But this is not an effect which we can transmit and translate to every serotype, but we just can say and realize that this effect had been shown, and probably for the future we must evaluate whether this serotype shifting has an impact, and therefore epidemiological studies are extremely important that we consolidate them. We already discussed in detail about these effects of infection, systemic inflammatory response to different pathogens, and I would like to translate that also to pneumococcal infection. And of course, we know, and we have seen that already, that acute infection, that inflammation and coronary stenosis depends, and also that myocardial infarction can be a later on effect after having systemic inflammatory reactions, which also can be caused by pneumococcal infection. And also we have seen that from the left part to the middle or to the middle and right part, this is a process which lasts for decades. And then finally, the intervention is that you really get plaque rupture, and then you get myocardial damage, and you get myocardial infarction. And that had been quite nicely shown in this paper in the New England Journal, that on the one hand side, you here have the features present at the time of cardiac involvement in acute infection. And then finally, out of that, the rupture of a plaque can occur, leading to myocardial infarction. And also in this paper, it had been cited that a meta-analysis of 8 observational studies all of which were published after 2000, showed a 17% lower risk of myocardial infarction among patients 65 plus or who had received pneumococcal polysaccharide vaccine than among those who had not. Very interesting paper, and it's really worth having a look on that. Also mentioned in this publication is the fact that if you have the dotted line as a basic level of cardiovascular risk ratio, if you have an upper respiratory tract infection, you increase your risk to have a cardiovascular effect. And it's not mentioned whether this is caused by influenza, by RSV, or by pneumococcal infection. If you have a pneumonia, that's a longer lasting effect. And if you have pneumonia complicated by sepsis, this is even worse, indicating that you can have this longer lasting effect even for not only for months, but even also for years. And why is this possible? That's probably explained by this paper, which shows that the post-recovery phase of acute pneumococcal community-acquired pneumonia is a longer-lasting effect. And that means that you have, for a longer period of time, obviously a lower level of pneumococcal presence in the blood. And that means that then you can maintain systemic pro-inflammatory effects, leading to prothrombotic activity that then finally may lead to delayed onset of cardiovascular events. And that also has been shown here, that if the lung takes up the pneumococcal bacterium, then finally it can lead to pneumococcal-mediated death and dysfunction of cardiomyocytes. Also, the intravascular activation of platelets and neutrophils can cause damage on the heart. And then finally, of course, the development of myocardial damage and dysfunction is the latest effect which you can realize. So what are these effects which you can see on the heart? And this is a paper which has shown the clinical outcomes with invasive pneumococcal disease. And they realized that 23% of the patients developed major adverse cardiovascular events. In community-acquired pneumonia, that was even higher, the rate, it was 28%. And having a look what have been these cardiac complications, you see that arrhythmias had been nearly in 60%, heart failure in nearly 50%, infarction nearly 30%, and myocardial injury in about 16%. Of course, this has also prognostic impact. So if you compare the group with major adverse cardiovascular events to the group which did not have that, of course they had an increased ICU mortality, the hospitalization mortality was significantly higher, and also the requirement for an ICU stay was significantly higher. Another study was doing a retrospective analysis from hospital admissions, and these have been more than 300,000 people with a vaccine-preventable disease who had been discharged, and 12,000 of them had heart failure with reduced ejection fraction. And associating these with the different vaccine-preventable diseases, there was a significant effect for influenza infection, but also for pneumococcal infection. So they had increased levels indicating that patients with HFrEF really are in the higher range and have a higher risk to develop such cardiovascular events. And that also has been shown in this plotting here. Influenza and pneumococcal infection had an increased hazard ratio, which you can see from this graph. And in the same paper, they also showed that that also was in sequence with higher in-hospital complications like mortality and also the higher need of mechanical ventilation. So the conclusion from this paper is that these results continue to emphasize why it is important to address influenza and pneumococcal vaccination in patients with HFrEF, indicating that there's an absolute need for giving not only the flu vaccine, but also giving the pneumococcal vaccine. There also have been other papers showing the association between pneumococcal vaccination and cardiovascular outcomes. This is a paper which showed it significantly with the conclusion that pneumococcal vaccination is associated with a decreased risk of cardiovascular events and mortality, that this protective effect increases at older age and in high cardiovascular risk subjects, and decreases as the time elapses from pneumococcal vaccination. So also clear plea that vaccination is necessary, pneumococcal vaccination is necessary in the elderly. Other studies have shown similar results, and this is something which shows that the polysaccharide vaccine decreased the risk for some adverse events, specifically acute myocardial infarction in the vaccinated population, and especially in the elderly above the age of 65. Other studies like these have shown that pneumococcal vaccination in adults at very high risk can also decrease mortality. This is the upper level of the graph, and the effect for major cardiovascular effect in the lower part of this graph was not shown. So this showed that pneumococcal vaccination was associated with a 22% decrease of all-cause mortality in patients with cardiovascular disease or at a very high cardiovascular risk. So what is our strategy? And I would like to show you that for our policy in Germany. We have a general recommendation of pneumococcal vaccine for everybody above the age of 60. And what we use right now is the 20-valent conjugate vaccine, which is available, at least in Europe, since about 1 year or even something more. But we do not give it only to this as a standard vaccination for this age group 60 plus. We also give it as an indication, that's what the I stands for congenital or acquired immunodeficiency, but also for chronic diseases like chronic liver, kidney, heart disease, diabetes, and also for neurological diseases. That also means that these vaccines are reimbursed and are completely free for the whole population if you fit into these strategies. Nevertheless, the vaccination coverage rate in the age group 60 plus in Germany is just 23%. And of course, you can have a close look to the different regions in Germany, really showing very different rates. And I doubt whether we would have a chance sending out letters, as we have shown and as we have heard from Denmark, increasing the coverage rate. This is really a problem because the trust in politicians and the trust into the health system is obviously not as good as we have seen that from Denmark. So as sort of a summary, I would repeat, if you have a chronic cardiovascular disease, you have an increased risk of severe cause of pulmonary infections. And that leads to acute respiratory infections which are associated with cardiovascular complications like the ones which I have mentioned already. And that means that you have increased morbidity and mortality with heart failure, myocardial infarction, and so forth. And this vicious cycle can repeat over and over again. So my summary and my conclusions are: pneumococcal and invasive pneumococcal disease cause substantial clinical problems. They also cause systemic inflammation, similar to influenza, but the effects have not been shown as convincingly as for influenza. Nevertheless, secondary cardio and cerebrovascular effects have been shown. We know that the conjugate vaccines are much better than the polysaccharide vaccines. Nevertheless, the vaccine studies which have been conducted are nearly all with the polysaccharide vaccines, and therefore there is an urgent need to also have data with the conjugate vaccines to show that we have a reduction in major cardiovascular events and also in all-cause mortality. In my view, everybody above the age of 60 should receive conjugate vaccines as we have implemented in Germany, and those with chronic underlying diseases, but we have very low coverage rates, at least in Germany. There are new vaccines on the horizons. The serotype shift, which occurs with that, must be observed, and therefore we really must pay attention to the situation, which is a moving field, and we must have a close look on that. But nevertheless, my plea is get vaccinated and avoid disease and physical inactivity. Thank you.
Thank you, Thomas. I think that if we don't have any urgent question, I would suggest to keep the discussion at the end of the session, because we have the last speaker who will connect at 5:30. So, okay, so I would give the floor to Marco now for the presentation on herpes zoster and incidence of cardiovascular and neurovascular events.
Thank you very much for the introduction and for the nice invitation. It's a pleasure for me to be here. I'm also a bit nervous staying here in this room with such great speakers. I feel like a little ant. But thank you for inviting me here again, and I'll be, talking about herpes zoster vaccine. This is the slide on conflict of interest, and I will divide this presentation on two different parts. Being the first one, herpes zoster and comorbidities and related conditions, specifically neuro and cardiovascular accidents. I called it a dual relationship because, as we've seen with other conditions, it's true that some comorbidities, some conditions can increase the risk of experiencing herpes zoster episode, but the other way around is also true. Herpes zoster episodes, as we'll see, can increase the risk of cardiovascular accidents and neurovascular accidents. And then we'll discuss a bit about what strategies do we have for prevention. So we know that herpes zoster is caused by the reactivation of a dormant varicella zoster virus. Primary infection generally happens in children. We also refer to it as chickenpox, but as it's typical for herpes viruses, the varicella zoster virus becomes latent when the infection, when the illness is not there anymore and it's cured and it's past. The herpes viruses, they become latent in nerves, and the varicella zoster virus becomes latent in sensory ganglia nerves. But we also know that it can reactivate due to certain conditions, due to immunosenescence, as we'll see, or other conditions that lead the individual to be immunocompromised. And the reactivation of the herpes zoster infection generally lead to painful skin lesions that are typical for this infection. And it is estimated that approximately 99% of adults over 40 years of age show serological evidence of varicella zoster infection, and 1 in 3 people develop herpes zoster in their lifetime. And the natural course of herpes zoster consists of an acute phase preceded by a prodromic phase with non-specific symptoms, then an acute phase with vesicular rash associated with acute pain that's very painful, that lasts 2 to 4 weeks. But we have to pay attention to the fact that 10 to 25% of people experiencing an episode of herpes zoster might develop herpes zoster ophthalmicus when the virus was latent in trigeminal ganglia. And also, up to 30% of patients can experience postherpetic neuralgia, which is a pain that can last, generally 1 to 3 months, but can last even longer, and it's very difficult to treat it. And also, it is estimated that 5% of persons experiencing an episode of herpes zoster can have another infection, can have a recurrence of it in their lifetime. Another thing that it's been now studied, and we know very well, it's that the incidence of herpes zoster and postherpetic neuralgia increases with age. It starts increasing a lot after 50 years, and it peaks around 70, 80 years. And these data are consistent through different populations and different countries. And the same is true for postherpetic neuralgia. And so the incidence of herpes zoster and postherpetic neuralgia are expected to rise due to the aging population, as we know, especially in high-income countries in these days, but not only in high-income countries, and the development of immunocompromising conditions associated with aging. So these are the two conditions, the two domains I've been talking about, immunosenescence on one hand and immunocompromission on the other hand. But the things are much more complicated than this because these two conditions can overlap in many cases. And it doesn't end with this, because if it's true that when you're experiencing, for instance, a condition like diabetes or cardiovascular disease, your risk of herpes zoster, your risk of reactivation of herpes zoster is higher. If you have two of these conditions, the risk is even higher, as shown by different studies that I've reported on the left hand of this slide. The first one is about a meta-analysis that pooled different risk ratios, and in those cases, those patients who were experiencing diabetes and cardiovascular diseases, or diabetes and specifically heart failure, had higher risk of herpes zoster episodes compared to those experiencing only diabetes mellitus. But this is also true for the other conditions, as you see in the charts. And on the other hand, since we were also talking about immunocompromised patients, these data come from a very, very large study collecting different registries together retrospectively, showing how the incidence of herpes zoster episodes is higher in immunocompromised patients compared to the general population. And it's not just only higher, it can be up to 10 times or almost 10 times in certain specific populations, in this case bone marrow or stem cell transplanted, but very higher, up to the double or the triple in other immunocompromised patients. So whether, let's say, the mechanisms, the pathological mechanisms are not that fully understood, but we know a lot, of course, and the first lecture explained us a lot about this. There's a growing evidence body that suggests that immune system dysregulation happens in certain cardiovascular pathologies. And for instance, in coronary artery diseases, generalized cell-mediated immunosuppression may increase the risk of herpes zoster, ultimately leading first to inhibition of T-cell activation, proliferation, survival, and functions, and in the end, defective specific adaptive immunity against varicella zoster virus. And on one hand, as I said at the beginning, the association between cardiovascular condition and risk of herpes zoster is known and well studied. I've here reported different studies investigating this, all leading to results meaning that the risk of herpes zoster in people with cardiovascular conditions was higher for those experiencing those conditions. For instance, well, it doesn't work on, yeah, well, thank you. For instance, you see MI, myocardial infarction, or ischemic stroke, or heart failure, and it's consistent through all the studies that have investigated this with different study design, population-based case control studies, or meta-analysis, for instance, one of Marra and colleagues, and we will also discuss this a little bit later. But what it's important to know it's that it does work on the other way around as well. So it's true that some conditions or some cardiovascular conditions increase the risk of herpes zoster episodes in certain populations. But it's also true that that herpes zoster episodes are seen and reported to increase the risk of cardio-neurovascular events. And for instance, again, a long list of studies, but more or less all consistently reporting that stroke after herpes zoster is higher, and the incidence of stroke after herpes zoster episodes is higher than in the general population. And the same is true for other neurovascular conditions, even if the stroke is the one being studied the most. And as reported for influenza before, this is especially true for the immediate period following an event related to herpes zoster. So the risk ratio of stroke or transient ischemic attack following herpes zoster is higher, especially after 1 month after having experienced the herpes zoster episode, and then the risk decreases over time. Same is true for myocardial infarction. It is higher, the highest in the first week after the first herpes zoster episode, and then it decreases over time. So we have seen how there's a dual relationship between cardiovascular, neurovascular events and herpes zoster, and both can increase, and each can increase the risk of the others. How there's an increased risk of stroke or myocardial infarction following herpes zoster is being extensively studied, but generally due to a vasculopathy that develops when the virus spread along nerve fibers and goes to the adventitia of the arteries, leading to inflammation, remodeling, and then ultimately to stroke, aneurysms. It's known that it's a possible reason and a factor for developing giant cell arteritis together with other viruses, for instance, a parvovirus. So at this point, we understand how it is very important to manage herpes zoster, and not only because of the pain brought by postherpetic neuralgia or the episode of herpes zoster itself, but also due to these other conditions that are increased and whose risk is increased. But we have also to acknowledge that it's not easy to manage herpes zoster, because we know that, for instance, there's no treatment, or better said, antivirals exist, but they need to be started within 72 hours of the rash onset, and they do not prevent an episode. They just reduce the symptoms, duration, and how the patient experienced the symptoms, and specifically until few years now. We had a vaccine that was the Zoster vaccine live that was very important, very effective, but with limited efficacy across the older adults, and that it was known to decline effectiveness over time, and due to the fact that it was live, contraindicated in immunocompromised population. We'll get back to this and then specifically talk about what happened in 2017. So since 2006 and drawn from the experience that we had with the varicella vaccine, we had a live attenuated vaccine that contained the Okameric strain that was indicated for the prevention of herpes zoster in individuals 50 years of age and older, but contraindicated in immunocompromised population because it was a live vaccine. What we knew is that despite it was the first attempt to prevent herpes zoster, and therefore very important, different studies reported, for instance, the shingle prevention study investigated people aged over than 60 years, how this vaccine had different efficacy, clinical efficacy in different age group populations, declining over time. And not only was more effective in younger adults, let's say, so those aged 50 to 59, but also waned over time. So the efficacy from clinical studies shown how after years of being vaccinated against zoster with the ZVL, the protection waned after years. And this was also confirmed by real-world data that the effectiveness of the vaccine decreased over time, and especially was decreased a lot after 5 years after being vaccinated. So of course there was a need for finding a new preventive tool that was highly effective in older adults and especially in immunocompromised population, and whose protection lasted in time. Since 2017, we have a new recombinant adjuvated vaccine. It's made with non-live glycoprotein E that was chosen because it's abundant and because it's very important to let the virus enter into the cells. That uses an AS adjuvant system, and that it's not live, as I said, so it is not contraindicated in the individuals who are immunocompromised. This is the composition with the antigen and the adjuvant system. And let's go to the clinical phase 3 and studies of efficacy, the ZOE 50 and the ZOE 70 that were published in 2015 and 2015 in the New England Journal of Medicine. There were randomized observer blind placebo-controlled multicenter multinational trials on over 18 countries, if I'm not wrong, that had as primary objectives, of course, looking at vaccine efficacy of herpes zoster in subjects either over 50 or over 70, and were conducted at the same sites. So the same site participated in these two studies with subjects older than 70 years of age, randomly assigned either to one group, the over 50, or the other group, the over 70. And the vaccine showed to be very effective for the prevention of herpes zoster episodes and postherpetic neuralgias in all age groups that were represented in these are the results of the pooled analysis, but results are consistent for both studies in all the age groups. And this is also true for the complications among group of over 50 and over 70 years of age. As you can see, the vaccine efficacy is over 90 when discussing population of over 50 and almost 90 in over 70 years older. And in a post-hoc pooled analysis, investigating non-postherpetic neuralgia complications, such as, for example, vasculitis, disseminated herpes, herpes ophthalmicus, or neurological diseases, the efficacy was also very high. So, well, this is just a summary slide saying that the efficacy was very high. I forgot to say that the patients were followed by, if I'm not wrong, a median of 3.8 years, 4 years. So it was high, very high in the 4th year post-initial vaccination. And it was very high disregarding the conditions reported by different patients, because the patients, of course, were asked to report different conditions when participating in the study. And in post-hoc analysis, it was shown that the vaccine was very effective. Well, the efficacy was very high despite different or disregarding different conditions being studied. In terms of safety, this is also very safe, and median duration of any grade solicited local reactions was almost never longer than 3-4 days, and as well the grade 3 were lasted even less, and the same is true for the not local but systemic reactions. So there was the overall incidence of adverse events, systemic adverse events, was similar between the vaccine and the placebo. And the majority of reactions, local and systemic, were mild to moderate and with short duration. There are also trials that went on specific populations. I've just reported some data related to them, but it's just to highlight that this is very important because it's the first time we have a preventive tool to prevent herpes zoster in these populations. And the first results, this was published in 2019, on patients after autologous stem cell transplantation that completed the 2-dose series. The vaccine efficacy was high, estimated to be almost 70%. And finally, one might ask himself or herself whether since with the previous vaccination there was a problem of lasting protection, whether this tool gives a protection that lasts longer. This is a long-term follow-up study conducted on the same populations of the ZOE 50 and 70, which results were presented, if I'm not wrong, at ECMID this year in April by Javier Diz Domingo from FISABIO, who is the principal investigator of the study. That show that this vaccine continues to provide high protection against herpes zoster in adults age 50 and over now for more than a decade. And this was conducted over 7,000 patients that were enrolled in the previous trials. So in recent times, of course, also real-world data have been coming. And for instance, this study that was published in Annals of Internal Medicine showed that indeed not only the effectiveness was very high, but it was specifically higher and lasting longer with a full cycle. So after 2 doses, and it lasted very high up to the 4th year. And the same effectiveness data came recently on another study investigating the association of herpes zoster vaccine and subsequent cardiovascular events in patients with dyslipidemia, hypertension, or type 2 diabetes, highlighting once more the importance of preventions in these patients, as this editorial that appeared in Stroke did, that vaccination against herpes zoster and potential to reduce the global burden of stroke, preventing episodes of herpes zoster. So in the end, and as said also by other colleagues in this room, yes, we have a preventive tool which is very important, very effective. It's being implemented and recommended in countries, this other recommendation you see in different countries. One, of course, the biggest problem we have at the moment is with coverage rates. I've just reported 2 studies, one study and a report from the CDC highlighting how the coverage rates are still low in target populations at the moment, both in European countries such as Italy and the United States. So this is something we should really tackle and we should really work on to raise coverage rates in the target populations, those for which the vaccine is recommended and that can benefit the most from this vaccination. So to conclude, the impact of herpes zoster on the health of older adults is significant, and we know it, and the same as for the immunosuppressed, immunocompromised patients, or patients that will be immunocompromised since they have to take immunosuppressant medication. We have a very effective tool in terms of prevention and in terms of efficacy and duration of the protection. We now having a challenge, which is the one to raise the coverage rates in the target groups, and this is what we should aim for. Thank you very much.
Thank you very much, Marco. And now I think we have, all right, very good. Elizabeth, can you hear me? Elizabeth?
Yes,
okay,
I can
good.
hear you.
Hi.
Hi everybody.
Thank you very much, Elizabeth, and I give immediately the floor to you for your presentation on RSV and cardiovascular disease in adults. Thank you.
Okay. So I will share my screen. Do you see my screen?
Yes. If you can put, right, perfect.
Yes? Okay,
Thank
good.
you.
So I would like to thank you for inviting me in this Congress. I'm so sorry because I cannot be with you in Venezia. I like this city, but maybe another time. So I'm Elisabeth Botelho-Nevers. I'm full professor in infectious disease in Saint-Etienne, sorry. And I work on vaccines in clinical vaccine development and also, of course, in my for care with patients in my center. And I also work on vaccines about acceptability. And it is notably in this area that I work with a student, a PhD student, and we look at what could be the determinants that improve acceptability among older patients. And notably, we think that some non-infectious benefits of a vaccination, such as prevention of cardiovascular disease, could be maybe a good argument, and we are looking at that in the thesis that I work with Alexandra Dario. So here my disclosures with many of industrials from vaccines and of course also for vaccine clinical development. So RSV is a virus, respiratory syncytial virus, and is a single-strand negative sense RNA virus of a paramyxovirus family. We have two subtypes, RSV-A and RSV-B, and we can see here there is more diversity in RSV-A, but both vaccines are ubiquitous and can circulate during the same season. It is important to know that for RSV, two proteins are important, notably F proteins, that is here at the surface of the virus, and this protein will be important for the virus entry in host cells, and notably the pre-fusion F protein. And I think you know that the vaccines that are now developed use this target. When we look at the seasonality of RSV, you can see here. Do you see my arrow here?
Yes, yes, we see.
Yes, okay. So you can see that during all the years, we have indeed RSV-A and RSV-B circulation, and it is frequently a period of co-circulations of other respiratory viruses. And here it's a French work commanded by Pfizer. And we can see that for RSV and the flu, we have a superposition in some month of year of circulations. And apart during the COVID-19 pandemic, we can see also that during for RSV, the seasonality is more regular than for influenza. The burden of the disease is very well known in birth and during birth and infancy, because of course there is a high burden of hospitalizations due to RSV due to bronchiolitis. But we can also see that it's a virus that can infect people at all the ages, and we have a weak reinfections because we have a weak immunity, and notably for elderly people, the burden of the disease is more important. We have knowledge that is more recent about the clinical impact and the burden of RSV in adults, notably because in many countries, as it is the case in France, we have no or very less epidemiological surveillance in adults. And we have also a politic, even if it changed more recently after COVID-19, about screening of RSV. It is very heterogeneous, and so we have less data about the impact of the disease on adults. Fortunately, nowadays we have more and more informations and data about the impact of the virus in adults. And notably, I don't put the detail here, but we have many data about the role of RSV, notably in transplant and pulmonary transplant adults and people, and also in immunocompromised patients due to hematological cancers or other cancers, and even people that receive medications that immunocompromised them are also at higher risk of infections and hospitalizations. Here you have also the data, the very recent data present in ASIP in February from the RSV network, that is a network of surveillance of RSV in the US. And you can see that indeed many people with chronic underlying conditions such as chronic kidney disease, but also, of course, and it is the topic of the day, coronary artery disease, and also cardiac insufficiency have a higher risk of hospitalizations. We can also see that according to the age, older patients per se have a higher risk of RSV related hospitalizations, but we have also people with underlying conditions and with an age more advanced that will have a high risk of hospitalizations. So there's categories of people, immunocompromised people, people with underlying conditions, and older people have a higher risk of RSV infections, have also a higher risk of RSV-related hospitalizations and death. When we look at the pathogenicity of RSV in adults, it is a virus, a respiratory virus, very frequent during its seasonality, that could be transmitted by droplets and from contact also, and notably in long-term care facilities, it will be an important way of transmissions. Usually, adults, we have firstly an infection of the upper respiratory tract with some systemic signs like fever, asthenia, and 2 or 3 days after, they will have also an impact on lower tract, respiratory tract, and infections of signs of infections in lower respiratory tract will appear. It is important to say, you can see here the comparisons on symptoms with RSV and with influenza. It is quite impossible clinically to distinguish RSV from other respiratory virus. It is the case with flu, but it is also the case with other respiratory viruses. And it is in this slide, I resume all the pathogenicity of the RSV in adults. We have the great majority of adults with RSV infection that will be symptomatic. Notably, people at risk have a high rate of hospitalizations. Among people that is hospitalized, we have a high rate of lower respiratory tract infections. And you can see here pictures from a patient of my center that was hospitalized with RSV infections. We could have respiratory failures in 10% and a high rate of death that could be up to 8%. RSV is also responsible of community acute pneumonia, and you can see that it is a cause that increases with age. We can have radiologically pneumonia in more than 30%. Bacterial co-infection is frequent. Viral co-infections could be also frequent, and antibiotics are more used with RSV than with influenza. And for some people, we can see that the reason of hospitalization is first the decompensation of their comorbidities, including isolated cardiac failure, for instance. So, RSV and cardiovascular disease. It is a double association. Indeed, we have people with pre-existing cardiac disease that have a higher risk for RSV infection. And RSV infection is also associated with cardiovascular outcomes. The first data that show that pre-existing cardiac disease is associated with a higher risk of RSV infection have been published, notably in children. And it is well known that children with congenital heart disease have higher risk for RSV infection, with notably a more severe outcomes, an increased need for hospitalization, longer length of stay, and also a higher rate of intensive care admissions. And before the use of nirsevimab, the monoclonal antibodies that is now recommended for all the infants, children with underlying congenital heart disease are a specific recommendation to receive palivizumab. In adults, the fact that pre-existing cardiac conditions increase the risk of RSV have been reported for the first time in the 19th with a study of Falsey. And we can see in this review published in 2018 that we have many studies that report few cases, but in these cases, sorry, excuse me. In these cases, we have a very high rate of people hospitalized with RSV and that have underlying cardiac disease. It depends on the series, but approximately 50% of people have been presenting. Okay. Do you see my screen? Yeah. Yes. In this review, it reviews a small series, retrospective, but we can see indeed this higher risk among people with underlying cardiovascular conditions. And it was also reported that in some series that the fact to have a pre-existing cardiac disease is associated with an independent risk factor for hospitalization. More recently, we have also data that confirm this association, and notably in this US study that look at hospitalization for people with HARI, acute respiratory illness symptoms, in 3 hospitals of the New York area with more than 1,000 RSV cases. We can see that among people that was hospitalized with RSV, about half of the people have chronic cardiac conditions. And it is interesting to see that people with coronary artery disease, but also and mainly congestive heart failure, are those with higher incidence risk. As you can see here is my, yes, here, notably for congenital heart failure, and it was the case in all the hospitals. Adults with congestive heart failure have a higher risk for 4 to 30 times higher for hospitalization compared to people without congestive heart failure. And it is the authors also remember that it's important to systematically test for RSV people presenting with congestive heart failure exacerbations, even if the presentation is not always associated with respiratory signs. And very, very recently, because this publication have a few days, it is a great publication from RSV network. It is a cross-sectional studies that look at hospitalizations among 12 states in the US over 5 RSV seasons before COVID-19 and also after COVID-19, with, you can see here, with very, very high great number of cases compared to the first studies that are retrospective with few numbers. We can see indeed that underlying conditions was present in about 50% of people, here adults with more than 50 years with confirmed laboratory RSV infections, and the majority have heart failure as underlying conditions or coronary artery disease. And, oops, sorry. And we can see, of course, because after in the second part we will see that people that have during the hospitalization more or one of acute cardiac event are frequently underlying conditions. So people with underlying cardiac conditions are at risk of RSV infections, but during RSV infections, we will also observe in patients a high number of cardiovascular events. And in the HIVA review, we also can see that we have even before recent publications, data showing that when people are hospitalized with RSV infections, about 20% in the series will have decompensations of some underlying conditions. But we will see that sometimes there is no underlying conditions. In this study that look at the occurrence of acute myocardial infarctions during the influenza seasons, we can see indeed that, of course, as everybody knows, I think, there is a high risk of acute myocardial infections in the days after influenza diagnosis, but we can see also even the risk is lower than for influenza. When there is an RSV infections, we can also have a higher risk of acute myocardial infections. For always the occurrence of cardiovascular event in during the RSV infections, always in this study published recently in the JAMA Internal Medicine, we can see that among the more than 6,000 people hospitalized, we observed 22% of occurrence of at least one acute cardiac event. It is interesting to notice even among people without documented underlying cardiovascular disease, 8% will present during RSV infections an acute cardiac event. And we can see that the more frequent events are acute heart failure or acute ischemic heart disease. And of course, among people that have already underlying cardiovascular disease, RSV infections will be associated with a higher risk of acute cardiac event. It is also important to see that when we compare people having an acute cardiac event compared to people without such event, people that experience an acute cardiac event have had a greater risk of ICU admissions and also a greater risk of in-hospital death. So how we can explain this association between RSV and cardiac disease? Always in the review of ESA, they review many explanations. First of all, of course, RSV infections may induce inflammations, and notably some pro-inflammatory cytokines, oxygen radicals, that could disrupt the endothelial functions. And it will be, of course, a reason to have an acute cardiac event. The inflammatory response also can lead to plaque destabilization and ruptures in patients that have a predisposition. During infections, not only RSV, of course, we can observe an hypercoagulable state and the risk of thrombose that could also increase the risk of cardiac events, but it could also have, even in long term, an impact on cardiovascular disease. And as for each infections, fever, hypoxemia could also increase the risk of atrial fibrillation, for instance. So now we have vaccines against RSV, and we look at the vaccines now available. There are 3 vaccines, one from Pfizer, one from GSK, and one from Moderna. It is quite impossible to compare the vaccine efficacy because in each of the phase 3, they don't look at the same outcomes. I think we can consider that all the vaccines are effective to prevent low respiratory tract infections. Sorry. To date, the vaccine of Pfizer and GSK have FDA and EMA approval. For Moderna, they have FDA approval only, but EMA probably will come in few days. When you look at countries that already have implemented the recommendation of RSV vaccines, we can see that countries all recommend the vaccine about in an age base, because as we saw before, we have people that are older at a higher risk of RSV infections, and they frequently have more underlying chronic disease. And in some countries, the vaccine is also recommended, including in younger people, based on the risk of the people. To date, it is all the vaccine of the Pfizer or GSK that are recommended. It depends on the countries. Of course, I think you understand that cardiovascular disease patients are frequent among older patients, and cardiovascular disease are considered risk conditions for RSV. So in all these countries, people having, according to the age, it depends of course, but cardiovascular disease are at a high level of recommendation for RSV vaccines. And to date, I'm sorry, but I don't have results to show you how RSV vaccines are or not an important way to prevent cardiovascular events. I don't have many doubts. I think really that a vaccine that prevents the disease will prevent also cardiovascular events, but it is important to show that, of course, in trials, but also in real life data. But to date, for the best of my knowledge, but I ask also, of course, for the manufacturers, they don't have these results, but it is sure that it will arrive in the future, because indeed we need to evaluate these vaccines, RSV vaccines, in the way they can prevent cardiovascular events, incidence, but also mortality, as it was shown for influenza vaccinations, with very elegant trials showing really that the vaccine decrease significantly the risk of cardiovascular events. It was also the case for COVID-19 vaccine, and another vaccine that is to prevent respiratory infections. Here it is data from Spain, Estonia, and UK, showing that the COVID-19 vaccination reduce after breakthrough infections COVID-19 the risk of thromboembolic and cardiovascular complications. And these data from Poland are also very interesting, even very preliminary, but they already published data showing that the simultaneous, the co-administration of RSV vaccine, here it is the vaccine from GSK, and a vaccine against flu, could be safely been administered in patients with high-risk heart failure. So it is an interesting way to vaccinated people, and even to vaccinate for many respiratory infections. And it is also interesting to show that there is no exacerbation of heart failure, no hospitalization, and no death among the 100 people that have been vaccinated. So the burden of RSV infection in adults is more and more recognized, notably thanks for some networks that have a great level of surveillance. People with underlying cardiovascular disease have really higher risk of incidence rates for RSV, but also risk of hospitalizations. Has other respiratory virus for an infectious disease is not really a surprise. RSV is also associated with acute cardiovascular outcomes. Of course, more among people that have chronic cardiac conditions, but also, and the data from the JAMA is very interesting, including in people without these conditions or with conditions that have not been diagnosed before. And acute cardiac events are associated with bad outcomes. So it is very, very important to prevent RSV infections in adults. Vaccines are indeed now available in future, in few months, few days. For France, it's probably in few months. And they will need to be used. And it is important to have studies, but also trials and real-life studies showing how these vaccines reduce the risk of cardiovascular events for our patients. Thank you very much. And maybe I can stop to share. It will be better like that.
Thank you very much, Elizabeth, for this very comprehensive, very interesting presentation. And if you can stay connected, we open the floor for discussion to the last three lectures. I don't know if you were connected before to listen to the
Unfortunately not, because I'm in in France. I'm part of the National University Council for our discipline, infectious disease. So I cannot attend. I'm sorry, but I'm sure it was very interesting, and I can stay maybe a few minutes again. Thank you.
Okay, so we open the floor for discussion. If there is any question for your presentation first, then. Marco?
So thank you very much for a very clear overview. Regarding the RSV vaccination in risk populations, what would your advice be with the current data? Do you regard seasonality there, like flu, or is the data enough to say that there's like 2-3 years protection so you can vaccinate anytime, anywhere?
I think the data from many seasons are interesting, indeed. Maybe I think they need to be consolidated. For the beginning, I think it is important to probably use the flu vaccination that is a vaccination that is recommended for a lot of years, and at the same time probably to co-administrate the vaccines. And after that, maybe we can also have vaccination at any time, as you said. But in my opinion, at the beginning, maybe it will be important to start in a seasonal vaccination like that after, even if it is each 2 years or more, we can have the same remember, and notably in countries, unfortunately it is not the case in France, but in countries where people really receive an appointment, etc., co-administration could be interesting. It's the reason I show the study from Poland. Of course, it's a few people, but it's important to probably already use this strategy to improve the vaccination coverage of at-risk patients.
Thank you.
Marco?
Yeah, thank you very much for your very interesting presentation. Just to follow up on this, I think scientific-wise, it's clear, and I tend to agree with you. We need to have good communication skills to do this, because then explaining to the population, for instance, why we are deciding to vaccinate every season, why not, or why do we vaccinate every season despite having good data, good protection, lasting protection for 2-3 years, might be difficult and challenging, especially as we've seen in COVID-19 times, if healthcare force, let's say, is not directed towards the same direction. So we need good communication skills, and we need to be all aware of which is the direction we should take, and be on that together once the decision is taken, to recommend the same thing to the population, I think.
Yes, thank you. I totally agree. And now is RSV. In the future, it is also other respiratory virus vaccines. And it will be very important to be clear and probably the more simple possible to protect the patients about their risk of hospitalizations and also bad outcomes associated with the virus. I totally agree.
Jane?
Thanks, Stefania. It's a question to my colleague here who's just made a great presentation, but also to the other presenters. There's an increasing challenge that we're not talking about, and that is that we don't have any harmonised schedules of vaccine respiratory preventable. We don't have any, sorry, I'll start again. We don't have harmonised schedules in any country across Europe with respiratory vaccines. And so we can see the problem of 3 different age eligibilities for flu, RSV, and COVID. That is significantly problematic when we're hoping for improved uptake rates. So I just put it out there because we just saw it on your screen, you know, different age eligibility. And we've got clear examples in every European country. Not one of them has a harmonised schedule.
Yes, I totally agree. Indeed, it is very complicated. And if you want to make the things the more easier possible, I don't think there is a big difference between 60 or 65. Indeed, in countries where the flu vaccine it's not at the same age, etc., I think it is the beginning for RSV vaccines. So probably people and national recommendations try to look what is the acceptability, etc. But probably it cannot help acceptability of vaccines in general in adult people and notably in older people. So my wish is that it's the more simple possible and allowing also co-administration. I think it could be a key for improving vaccine coverage.
Just a quick comment to follow up. I think that we're talking about 2 different things here. You know, across the course of the afternoon, we've heard very clear evidence. The science is there, but the scientists don't have the budget. And so,
sure.
And so, you know, all the scientists here today would actually be able to understand and implement, you know, a relatively harmonised schedule. But increasingly, governments are making decisions based on not only return on investment, but they're also taking risks to save money. And that's a real policy issue that scientists need to get behind as well, because without the scientists, then we're not going to be able to make the argument.
Yeah.
Well, nevertheless, I think we have, my personal view is that it's really extremely difficult to get harmonization in these, all different European countries. And just have a look on Italy, you have so many different recommendations that's really tricky even in one country. Nevertheless, I think it is a good chance to sell these vaccines, and you mentioned that as respiratory vaccines, and of course you can include RSV, influenza, COVID, and also pneumococcal infection as sort of a package. The problem is that we have different latency when to repeat the vaccine, and therefore it's very difficult and hard to give a clear recommendation strategy. And that makes it even more difficult to get it harmonized.
Look, and I totally agree. Look, I'm certainly not being black and white, but I'm just trying to present the real issues for consumers, the general public, when they've got to go back 3 times in a period of 3 years. And to be able to communicate why that is so is really difficult. But I appreciate your comments and I agree with them.
Stefan?
So I'm going to echo a little bit of what Jane just said. I think RSV is also a special case. Influenza has been around for a long time, and COVID has been in our face, you know, quite acutely. But outside of the people like us, they really don't know much about RSV. And I think for the consumer, we have a challenge in that how do you expect them to keep track of 2, let alone 3 or 4 different vaccines? And I agree with Thomas in that I think the way to do it is to bundle it and not tell the consumer there's 4 vaccines, but to say it's time for your respiratory vaccines, and let the providers figure out which ones they need. And I think to make that work, the policy question that you were bringing up is a slightly different one. And that is that the regulators have to require registration of who gets which vaccine, so the provider on the front line knows what to give. So somebody has to have a vaccine uptake registry that's shared between pharmacies and providers.
If I can, I totally agree, because I don't show you because I'm afraid to be a bit late, but few data have been published about the knowledge of older people, for instance, about RSV, and this knowledge is very low. People don't really know. They know about bronchiolitis in children, but they don't know. And even among healthcare workers, we need to indeed increase the knowledge of the burden of RSV in adults. So I think we need to do that, but probably it is more simple and more effective to create indeed a bundle and a package, as you said.
Yeah, so I think there's an aspect to this also that is, I think, thanks to the conference here, that's worth mentioning, and that is, this is not just a respiratory vaccine package. This is a cardiorespiratory dementia prevention package, and that's the way it needs to be framed for to maintain functional independence, quality of life.
Okay, so thank you very much, and I'm sorry.
Yeah, Jody, I will be very short, but I think what we are discussing is when to start, what kind of bundle, and so on. And I don't know if this is so different like in young children, where we all have that. We have clear plans, we have bundles and so on. So why not to go back and look how they achieved that? Because we probably can learn from that point. I think, what we propose here is quite, in some way, quite similar when it comes to propagation and so on. So I would ask them what the problems they had when they started, or if there are a specific problem in different countries with that, and how they would like to deal with it. But we could profit because we speak a little bit about the both ages of life and how you convince. And in children, you convince the parents, and in older adults, you convince the children if you want to have success.
Okay, Elizabeth, next time try to be here in Venice with us.
With great pleasure. I'm sorry. To be honest, I'm in Mont Saint-Michel. It's not so bad, but it will be a pleasure to be with you in Venezia. Thank you.
Thank you very much. Thank you. We will contact you for the executive summary that will be prepared after the meeting. And
okay.
Thank you again.
Thank you so much. Bye.
Bye, bye, bye. Okay, so do we have any other general comments, statements, suggestions? If not, I will give the floor to Michele, who will tell us the next plans for the evening.
Yeah, I think that we can close for today and then.
No, Michele is saying that we can close the session for our colleagues, and then we may discuss all the other things for the evening, when to start and so on. Okay, can we stop the streaming? So for all